Hello, hi, and greetings, everyone. This is Dilip once again. Welcome back to another session. We are going to continue with where we left yesterday. Can you hear and see me properly? There's no problem, right? Yes. Thank you. Thank you, Hari. Thank you, Keshav. Yeah. Okay. So let us start with where we left yesterday. I think today's topic will be on renal failure, and probably we'll be discussing on the tubular interstitial disorders as well, and we'll complete most probably today. So that's what I'm trying to tell. Maybe from tomorrow we can start with hepatology and the GIT section, the most important concepts of hepatology and GIT. I think if that is done, then with already the existing 3 chapters in the app, I think you will be almost be covered. So there won't be any problem after that. So once I finish the hepatology and some important medical concepts of gastroenterology. So today anyway, we'll be continuing with the images that we didn't see yesterday. So I compiled all the images from my old laptop. So I just put it across here. So to start with, first let us start with certain images which are important for exams. Maybe I'm going to show some 15-20 images maybe, so which is important for exams. So first of all, what do you see in this light microscope? This is basically a light microscopic image to start with, this one I'm talking about. So if this is going to be a light microscopic image, and what do you see really? So what is the arrows are showing here? Yes, of course, there is more cells. And if there are more cells, then what do you really mean there? So what you're seeing, in which area you're seeing more cells? This is basically a characteristic mesangial hypercellularity. Yeah, there is a mesangial hypercellularity. So that's what you're seeing here. So as I told you yesterday, the definition of mesangial hypercellularity is little variable. Some books will tell you more than 2 cells or more than 3 cells. So by definition, anything more than 3 cells, or which means usually we don't count by cells, we see 3 nuclei. Anything more than 3 nuclei in the mesangial area. So this is a capillary loop we can see here. So these are capillary loops, and surrounding that, I think you can see the mesangium. So this is basically the mesangial area. So anything more than 3 nuclei in the mesangial area is supposed to be mesangial hypercellularity. So this is a mesangial hypercellularity. Suppose if you talk about a mesangial hypercellularity, is it specific for IgA nephropathy? Answer is no, but usually in exam it will be IgA nephropathy whenever they give this kind of mesangial hypercellularity. But I don't really think that. This is a very specific finding for IgA nephropathy. You can see in many other conditions as well. And apart from that, this is an immunofluorescence finding. What you're seeing here. So this is the typical mesangial area where you're seeing a lot of granular deposits. So if you see this kind of granular deposit in the mesangium, it doesn't mean it's IgA nephropathy, and you have to see the IgA staining. If IgA staining is positive, then it could be IgA nephropathy. Again, it could be, but there are many other conditions which can produce IgA deposits in the mesangium. It's not just your IgA nephropathy, so which you have discussed already yesterday. So these 2 images in the exams usually go towards an IgA nephropathy. But apart from that, they are really non-specific, and there are a lot of other differential diagnoses for the same which you need to consider in mind. And second one, so what do you mean by this? So this one is to start with, we start with light microscopy always. So what is this typical picture? So this is definitely not a normal glomerulus. So normal glomerulus look much less cellular than this one. So this glomerulus, like you see too much of cells. So this is too much basically. So there are too much cells here. So too much of cells. You really can't really tell which is capillary loop, which is the mesangium, and which is epithelial cells. So these kind of small details are lost here. And the entire glomerulus looks a bit bulky, and at the same time you see too much of cells. Some of them can be inflammatory cells, like for example maybe this could be an inflammatory cell infiltrate. So at the same time, there's an entire glomerulus which is actually hypercellular. So as we have been discussing yesterday, more than 100 nucleus per glomerulus is characteristic definition for something called as a glomerular hypercellularity. So whenever you see this kind of entire glomerular hypercellularity, what is the disease that you're dealing with? Please don't tell PSGN, for God's sake. So whenever you see an entire glomerular hypercellularity, you are going to diagnose something called as an APGN. This is called acute proliferative glomerulonephritis. That's what we're going to diagnose here. So one of the examples of acute proliferative glomerulonephritis is IRGN, and one of the examples of IRGN is PSGN. So that is post-apoptotic glomerulonephritis. So this is just PSGN is just a subtype of IRGN, which is itself is a subtype of APGN. So that is acute proliferative glomerulonephritis, and this is what you need to really diagnose when it comes to exams. Clear? So this vaguely goes towards a PSGN, not 100%, but this vaguely goes towards a PSGN because here you see this typical garland kind of a pattern. So I generally stick on to this term garland because this looks like a flower and a garland. So I stick on to that particular term. But even though there are multiple other terminologies for this in the name of maybe starry sky pattern or whatever it is. So this is basically the garland pattern that we see in patients with PSGN. So this vaguely, not entirely specific, but vaguely specific for PSGN, post-streptococcal glomerulonephritis, probably. And apart from this, we have some other pictures to see for. So what is this picture? This is very simple to tell. It's not a very difficult thing at all. So what is this? What you're seeing here? Yes, of course. This is basically a crescent that you're seeing here. This is the crescent we are talking about. So this is something like a crescentic glomerulonephritis. So you see a crescent. So that's a very simple thing. And this is another example of a crescent. If you look for, you can see this is a crescent that we are talking about. This is parietal epithelial cells. But why the staining is positive? Is it IgG or IgA? So what is the staining that is done here? Can anyone tell what is the staining that's done probably here? So I told you probably there is one thing that glues this parietal cell together, that is fibrinogen. So basically this is a fibrinogen stain, and we can see there is a lot of fibrinogen that is actually gluing the parietal cells together, and that is basically crescent. How a crescent looks like. And what is this one? So what is this? So this is not a crescent basically. So here my idea is not to show the crescent, but to show one disease that is associated with the crescent. You can see the capillary walls. So these are the capillary walls. So the capillary walls are basically stained with, these are not wire loop lesions basically. So these are the capillary walls that are stained with wire loop lesions. Typically 11L you will see in light microscopy. In immunofluorescence we don't call it as wire loop basically. So wire loop lesions are very characteristic in light microscopy for lupus nephritis, not for immunofluorescence. In immunofluorescence you see this kind of lesions. This is a linear staining pattern that you see here. So the capillary walls, even if you zoom and see, I don't think in high power you will be seeing any sort of granularity here. So there is absolutely non-granular. It is smooth linear deposits which is associated with the crescent. So of course this is anti-GBM antibody disease. So smooth linear deposits, anti-GBM antibody. Remember, whenever you see this kind of smooth linear deposits, basically this is an IgG staining, plus you can have albumin staining also. Whenever you see IgG and albumin in the base membrane, and you have a smooth linear capillary wall deposits like this, typically it goes towards two differential diagnoses. One is anti-GBM, another is diabetic kidney disease. Both these things can result in same kind of pattern, but usually, like it's going to be GBM in exam, because GBM is the one that produces anti-GBM antibody disease, the one that produces characteristic glomerulonephritis. So in DKD, the urine typically will be bland, isn't it? Whereas in glomerulonephritis, the urine will be, sediment will be active, like RBC cast, dysmorphic RBC, so many active sediments will be there. But in the setting of diabetic nephropathy, the urine is going to be bland. And even though for theoretical reasons, DKD is a differential diagnosis, who is going to do immunofluorescence for a patient with a diabetic kidney disease when the urine is bland? So one of the important indications for a biopsy is active sediment. So without active sediment, I don't think it's justifiable to do a kidney biopsy in the first place. So even though the DKD is theoretically one of the differential diagnoses, I don't think DKD can be really diagnosed. It's only for namesake. Practically, we don't think about DKD. It's all about our anti-GBM antibody. So whenever you see a crescent, when you see a lung involvement along with kidney involvement, and if you see this kind of linear staining pattern, so this is suggestive of a Goodpasture syndrome. So anti-GBM antibody kidney disease. But please do understand the fact, when you see a crescent like this, and immunofluorescence looks dark. If immunofluorescence is negative, you don't see anything like this, what I have shown, then it could be ANCA-associated vasculitis. You need to know about that as well. Okay. So let us see this one. So this is basically the minimal change disease, but this is not specific for minimal change disease. In minimal change disease, this is the only finding that we'll be seeing basically. To start with, you can see there are no food process of podocyte. Normally, the podocyte should look something like this. So the food process will look something like this. But here, I don't think you can see any food process that is looking like that. So this is basically fusion and disappearance of the food process of the podocytes. The food process may become like sausage shaped, and this is basically a minimal change disease. In the sense, like, this is not only minimal change disease, there are many other differential diagnoses for this. You can have fusion of food process of podocytes and disappearance of food process of podocytes in focal segmental glomerulosclerosis. You can see that in membranous nephropathy as well. You can see in other congenital forms of nephrotic syndrome as well. So it's not very specific for minimal change disease, but nevertheless, that's very important as well to know. But remember, in conditions like membranous nephropathy, even though there is fusion of food process of podocytes, you'll be seeing other findings like electron dense deposits will be there. But in minimal change disease, there will be normal cells, no deposits whatsoever. Immunofluorescence will be negative, light microscopy will be negative. The only finding you will be seeing is the fusion of food process of podocytes. That's what you're going to see. And once again, here you can see this is a flattening of the podocyte. So there is no food process that goes out like this. It's a flattening of the food process of podocytes. Along with that, at one area there is no food process at all. It is complete resorption of the food process of the podocyte. This is very bad. And this is another example of a minimal change disease. No deposits, normal cells, only food process of podocytes effacement, typical of a minimal change disease. Everything else is normal. So this is an example of a thickened base membrane. You can see there is some capillary walls. You can see this is a capillary loop, and you can see the walls of the capillaries have been, like thickened like anything. So this is a diffuse capillary wall thickening, and this is typically suggestive of a membranous nephropathy. So very classic. And at the same time, this is a silver stain that clearly shows one important pattern. That is, this silver typically stains the proteins within the base membrane. And what you're really seeing here is this kind of spike-like appearance of the base membrane, even though it's typical in electron microscopy, but even in silver stain, even light microscopy in high power, you can see these are some spike-like appearance of the base membrane because the silver stain stains the base membrane. So these are the basic epimembranous spikes, which is equal to membranous nephropathy. So that is in light microscopy. Clear? So then we do have the immunofluorescence finding, which is very characteristic once again. As far as the immunofluorescence is concerned, I mean, it's difficult to tell whether it is epimembranous or subepithelial, or typically you see in the subendothelial region. You can't really categorize based on immunofluorescence, especially as a beginner. But as you see more and more patterns in the pathology lab, you will be able to tell this is subepithelial, this is subendothelial. To start with, most of the deposits will be in the capillary walls only. It looks as if in the capillary walls, even if it is subendothelial or if it is subepithelial or epimembranous or on the capillary wall, you'll not be able to tell. So where is exactly, but there are some patterns over time you will be able to tell, but this is too early for you to understand in pathology. But nevertheless, this is a capillary wall staining, which is more of a granular in appearance. This is a granular capillary wall staining. And I think in, if you zoom a little bit and you can see, this is not a very smooth pattern like what we have seen. It is more granular. You can see this chunky, like deposits. This is a capillary loop. They're seeing on the walls of the capillaries, you can see this kind of granular deposit. This is not a very smooth deposit. So this is typically a granular kind of a deposit that you see on the capillary walls. It's more on the subepithelial region. Suppose that is why you need to always compare the light microscopic image and the clinical picture as well. The patient coming with a pure nephrotic syndrome, and if I'm going to see a light microscopic image like this, and I'm seeing a capillary wall staining, something like this, typically I'll be diagnosing as an IMGN. So that is an idiopathic membranous glomerulonephritis. That's what I'm going to diagnose basically in this particular example. So you need to compare and contrast. And this is an example of an electron microscopic image which shows this spike and dome kind of a pattern. So I can draw with a different color. Maybe this is the immune complex deposits that I'm seeing underneath the food process, the podocytes. And at the same time, there are some base membrane spikes as well, like this. So this is the characteristic, the spike and dome pattern. These are sub-epithelial, or probably we can call it as epimembranous deposits, electron dense deposits, producing that characteristic spike and dome appearance. So you can see this is the dome that we are seeing, and this is the base membrane spike that we are seeing. So this is what we typically refer to as the spike and dome appearance that we see in the IMG, idiopathic membranous glomerulonephritis. Remember, it can be variable in other types or secondary types of MGN, but characteristic thing that you get in exam is the IMGN, idiopathic MGN. And this is something interesting. This is an example of a membranoproliferative glomerulonephritis. So where you see this kind of double contours. You might ask how there is a double contour here. Yes, there is a double contour. I mean, what do you mean by a double contour in the first place? There should be two different areas within the base membrane. So that's how we find out a double contour basically. To start with, you can see this base membrane, you have something like a thicker or a darker kind of region here, and in between you see some lighter kind of region. If you want to shade the lighter region, you can see there's a lighter region here. So which means there are two different things that appear within the base membrane. So this is typically double contour that can be seen sometimes in light microscopy itself. And once again, you can see there are a lot of areas here. So this is an area, this is an area, and in between you see something lighter. So it appears as if the base membrane has different components within it in light microscopy. So in many areas you can see that. So for example, you can see here also the same. It appears as if the base membrane is having two different areas within it. So even though the base membrane is thickened here, so it appears as if it's having a double contour, tram tracking, split appearance, whatever you can call it. I call it as double contours, which is more appropriate. So that's why this is called as an MPGN. This characteristic finding of a membranoproliferative glomerulonephritis, it could usually seen in type 1, type 3, but can be seen in type 2 as well. But very classic in type 1 and type 3, but it can be seen in any type of MPGN basically. And you can see, note that the overall cellularity of the glomerulus is actually quite high. If you have ever visualized the normal glomerulus, you will be easily able to appreciate that. But if you go to the IMGN, in IMGN, you don't see that many cells. I just see the glomerulus is a little bit high. I mean, the base membrane is a bit thickened, but overall, if I see the cells, it's fine. So compare this with this one. So of course, I'm seeing more number of cells here. So there's no doubt about that. So this is proliferative as well. And where it is proliferative, which means you can see in an example region is this, where typically the capillaries in the mesangium is actually proliferating. So this is a mesangiocapillary, otherwise membranoproliferative glomerulonephritis. And this is an example of a double contour that you basically see within the base membrane. And probably if you take, this is one wall and this is another wall of the base membrane. In between, you can see this kind of deposits that are actually producing something like a double contour appearance or a split appearance of the basement membrane. So this is an electron microscopy, double contour appearance. And this is an example of a subendothelial deposit, which you can have a look at it. Subendothelial deposit underneath the endothelium. So this is the base membrane. Maybe I can draw here. So this is the base membrane and this is the capillary endothelial cell, and you can see it is between the base membrane and the endothelium. So this is a subendothelial deposit to start with. And this is another example, very characteristic example. So this is a dense deposit disease, very, very typical in exam. You can see this kind of dense deposits within the base membrane. We can have write in different colors. So these are the dense deposits within the base membrane. So this is what we refer to as a triple D, otherwise called as dense deposit disease. So within the base membrane, you are seeing this kind of dense deposits. And this is a characteristic mesangial ring. So it appears as if the mesangium is forming a ring, this kind of immunofluorescence forming a ring. So these are the typical mesangial rings that we see. That is equal to, again, triple D, dense deposit disease. This is one of the typical findings of MPGN type 2, but even though it's not absolutely specific, but still typical finding of an MPGN type 2. Then this is another category where you can see there is a focal area in the glomerulus that is actually hyalinized too much, which means they're showing too much of pink material, pink extracellular matrix in between. So this is the extracellular matrix, that pink color that you see here. So of course, this is going to be FSGS, focal segmental glomerulosclerosis. And at the same time, you do see with the Massen's trichome, which stains the collagen. So you can see area of glomerulus that is actually containing too much of collagen and extracellular matrix. This blue color, what you see here. So this is an example of a focal sclerosis, that is a focal segmental glomerulosclerosis. I mean, you can tell from this image, you can tell it's a segmental glomerulosclerosis, but you cannot call it focal, because for 12 focal, you need to have different glomerulus from different views. So out of 10, I told you if only 3 are involved, then you call focal. In the same glomerulus, involved glomerulus, if you take only some part of the glomerulus involved, that's called a segmental. So with one glomerulus, I'll be able to tell it's a segmental glomerulosclerosis, but I'll not be able to tell it's a focal, because to tell it's focal, I need to visualize many different glomerulus. And this is another example of a glomerular disease. Typically, wire loop lesion we see in SLE. So you can see this, there is a immune complex deposition. We don't know whether it's immune complex or not, but there is some material that is getting deposited around the capillary walls. These are the capillary that we see, and around the capillary walls you can see there is some material that is getting deposited. These are the typical wire loop lesions that you generally see in patients with SLE, but even though not specific, you can see once again capillary loops. These are the capillaries, and around the capillaries you see some this kind of immune complex deposition. So this forms a typical kind of a wire loop kind of lesion. So remember, more the immune complex deposition, more the number of cells, more the hypercellularity, more the proliferation. So more immune complex always means more damage. And in this setting, if you do immunofluorescence, you will be seeing something different. There will be, of course, an immune complex deposition. There's no doubt about that. So this is the full house pattern that you see in patients with SLE. So you can see that every single stain is actually staining positive. IgA, IgG, IgM, kappa, lambda, C1q, C3, fibrinogen, every single stain is actually positive. So this is basically a full house pattern of immunofluorescence that you see. Again, typical of lupus nephritis. And probably this is an example of another glomerular disease which we don't really have seen. This is a hereditary glomerular disease, that is an Alport syndrome. You need to know Alport syndrome is something that can be inherited through autosomal dominant, autosomal recessive, X-linked recessive, X-linked dominant. But I do believe X-linked dominant is a common type, even though this is not a question in exam, but it can be inherited through any different pattern of inheritance. Doesn't matter. Alport syndrome in exam, the clue will be, one is of course the family history, which will be very prominent in exam. Either hematuria or renal transplantation or some form of family history of kidney disease will be there. And eye and ear involvement will be there. Patient might have sensorineural hearing loss. Patient might have vision problems like keratoconus. So many problems can be there. So as far as Alport syndrome is concerned, and along with that, usually they initially come with history of recurrent hematuria. History of recurrent hematuria. That's how they come. And this recurrent hematuria, slowly they might progress towards CKD by around second or third decade, they'll progress towards CKD. Usually recurrent hematuria is the one that will be seen in the first decade of life. First decade, typically you will see recurrent hematuria, but in second decade, slowly they will progress towards CKD. And more often, they might be asking you, what you will see in electron microscopy. In electron microscopy, this is what you will see. You will see this kind of thinning, thickening, splitting. So that base membrane will be irregular. So even though, I mean, you will be telling that basket weave appearance is one that is seen in electron microscopy, that more than a one-liner, in reality, that doesn't have much significance. Typically, I'll be diagnosing clinically only. If I do a electron microscopy, only one finding I'll be seeing, that is irregular base membrane. Irregular basement membrane. So that is the only one thing I'll be seeing. So what I'm seeing is an irregular base membrane here. So I can see at one place it is a little thick. At this place it's very thick. At one place it's extremely thin. So this kind of thickening, thinning, splitting of base membrane, so which means more often an irregular base membrane is what we call it as a Alport syndrome. That's what's seen typically. And but even though always students want that one-liner point, isn't it? So you see that basket weave kind of appearance. That's again due to that irregular thickening and thinning of the base membrane. That's what you're going to see. And as far as Alport syndrome is concerned, one of the important differential diagnoses there, that is called a thin base membrane disease. Thin base membrane disease, that's a differential diagnosis as far as Alport syndrome is concerned. But remember, thin base membrane disease may have a family history. They might have a history of recurrent hematuria, but no CKD. The patients will not go for CKD. It's more of a benign disease, and ear and eye problems will not be there. No ear and eye issues with thin base membrane disease. So this is how you differentiate Alport syndrome from your thin base membrane disease. There are multiple other differential diagnoses out there, but this is the usual case. So strong family history, eye problem, ear problem. Think about Alport syndrome in exam. So this is how you diagnose. Electron microscopy, irregular base membrane, and probably that basket weave pattern that you need to know. So treatment of choice for Alport syndrome is typically transplant only. There's nothing else that you can do. No immunosuppression works because there's a congenital problem. We know what is the problem. It is in the alpha 5 chain of the collagen 4. So that's why it's called 4A5 gene involvement. So which typically involves the alpha 5 chain of type 4 collagen. Collagen type 4 alpha 5 chain is defective here. So treatment of choice is transplant, one of the diseases that has excellent prognosis after a transplant as far as kidney is concerned, because if you replace that abnormal base membrane, the entire disease will settle. So that's the idea. But one small problem is there post-transplant. There is a small chance, not a heavy chance, but there is a small chance of increased risk of anti-GBM antibody disease. Because this is a new base membrane, actually the problem in Alport syndrome is the base membrane only, especially in patients who do not have any basement membrane at all in the first place. You might transplant a kidney that has some basement membrane, and in that case, the body might recognize that base membrane as a little different and antigenic, and they can start producing this anti-GBM antibody. So except for this small risk of producing this anti-GBM antibody, Alport syndrome generally does not recur in the transplant. If they ask you which disease does not recur in the transplant, I call Alport syndrome as the first because it's a genetic problem. So why it has to recur in the transplant in the first place? So it's a deficiency of base membrane. So replace that with a good base membrane from another kidney, so the disease is going to resolve. That's the idea. So this is another glomerular disease, which is something important. So where I'll be calling this as diabetic kidney disease. In DKD, even though this is a characteristic DKD lesion, so this is what we refer to as a nodular glomerular sclerosis. You can see this pink hyaline material that is deposited in a nodular fashion. This is a Kimmel-Steele-Wilson lesion. Everyone will be aware of that. So no need to tell multiple times regarding this. So this is a typical Kimmel-Steele-Wilson lesion, nodular glomerulosclerosis. Even though this is quite pathognomonic for diabetic kidney disease, but it's not seen in many of the cases. But some of the characteristic changes that you see is this microaneurysms. I can see some of the capillaries are dilated a little bit. So these are the typical microaneurysms that you develop with diabetes. This is more common, even though these are not specific findings, but these are more common in diabetic kidney disease compared to the nodular glomerular sclerosis, which is more typical. And you can see, I mean, I would say the mesangial matrix is a bit little more compared to the normal glomerulus. So if you see the normal glomerulus today, go home and see the normal glomerulus, you don't see this much of matrix. I don't think you can see this much of matrix in the mesangium. So little mesangial matrix enlargement is there. Like for example, this is called a diffuse mesangial deposition. So of some proteins, so that's what happens in diabetes mellitus very commonly. At the same time, you can see a vessel. So this is a vessel basically. In this vessel, you can see some pink color material that is getting deposited in the vessel. So this is nothing but hyalinization of the arteriole. So that's quite common again. So that is arterial hyalinization. You can see this is a vessel. This is another vessel where you can see some small pink color deposition here. So that is hyalinization of the arterioles, quite common in diabetes mellitus. And at the same time, this is another probably pathognomonic lesion that is seen in diabetes mellitus. So you can see some material that is deposited here. Usually in usual routine microscopy, you will have this pink color material that will be deposited, but this is a special stain, so you can see this blue color material that is deposited. So this is what we refer to as a capsular drop. Capsular drop is again extracellular matrix protein deposition between the visceral epithelial cell, parietal epithelial cell and the Bowman's capsule. So you have a parietal epithelial cell and you have a Bowman's capsule. In between parietal epithelial cell and the Bowman's capsule, there will be some proteinaceous substance deposition. That is what we refer to as a capsular drop, almost pathognomonic for diabetic kidney disease. So usual findings that you see is these 4 findings. That's the classic findings that you commonly see in diabetic kidney disease. One is the microaneurysm. Second is the arteriolar hyalinization. Third is the diffuse mesangial expansion with a little bit of proteinaceous substance here and there. And fourth is the capsular drop. So these are the usual findings that you see, even though these findings are pathognomonic. So that is the Kimmel-Still-Wilson lesions, but this is not very commonly seen in diabetic kidney disease patients. I think this must be it. So these are the images that you generally see. I've shown you all the crystals and casts, I think, already in the previous sessions itself. So I don't want to show it again. So I think kidney wise, you're done with the images. So I don't think you need any more images to do as far as kidney is concerned. So do you understand, so that we can move on to the next one? Okay. Okay. So I think after this short discussion of this image section, let us move on to the kidney injury part. So renal failure part as such. Acute kidney injury and chronic kidney disease, and probably treatment of acute kidney injury and chronic kidney disease. I mean, first of all, to start with, I need to put a disclaimer that there are so much is there. There are certain topics which are very difficult, and at the same time, there is too much to learn. Of course, cardio, and second is neuro to an extent, but again, neuro is something how you take. If your primary goal is to prepare for exams, neuro can be concise to maybe 40-50 pages, nothing more than that. But cardio is a little more. And similarly, kidney, endo is not that much. You know, like if your primary goal is to prepare for exams, endo is maybe you can accommodate in 30 pages, 25 pages max. So that is the stuff that you need as far as endo is concerned. Even for respiratory medicine, same thing applies. You need like 20-30 pages of stuff. That's all as far as exams are concerned. And please teach endo. I mean, Kritika is not a regular subscriber, I guess. So in the regular subscription, I've already completed the endocrine almost completely. But anyway, I'll be doing here in a crisp way. But I've completed in detailed discussion in the routine videos itself. How can you get these kidney images? I mean, typically I got these kidney images from one of my friend's website. So that is Renopath. Renopath is in Chennai, renopath.com. So I got this from there. If you want, you can get there. Or if you want, I can post these images in the group today, maybe. Okay. So next thing, what we need to know is the kidney injury. So that's what we wanted to start with. So first is the AK, that is acute kidney injury. I think we have discussed about the definition of AK already, but let me tell one more time. So what is the definition of an AK? Definition of AK is based on two things. One is based on the serum creatinine, and second is also based on the urine output. So you need to tell about the serum creatinine, and second, you need to talk about the urine output. Easy PDF I'll share with you soon. Maybe today. I completely forgot that. So because sometimes in the morning I get held up with this online consultation. So now teleconsultations are going on, and these patients never leave us most of the time. So they keep calling, and so I don't want them to call my phone. So I do with some teleconsultations. Sometimes it becomes too much over my head. So that's why today also there was a small delay was there. But nevertheless, now I am in a break because I've been done with the surgery. So I'm not going for the next week or so, because at 30th I'm having another surgery, and maybe I'll be back. I mean, after 30th, first, second, definitely I cannot get up because it's a major surgery. I'll be in the hospital only. So second, third, maybe I'll be coming back home and for resting in the post-op recovery period, and maybe from fourth I'll be kicking on back. So fourth, probably I'll be up and running, hopefully, fingers crossed. And from that time onwards, I'll be starting to do my regular activities as well. Right now I'm not training as well, so I need some physical training also, because for the last 1.5 months I've been not training at all. Like, I'm not doing any exercises. Usually I have my swimming pool in the apartment, so usually swimming is very like one of my favorite things to do, so which I'm not doing for a long time. So once I start with my swimming and maybe with my table tennis, I think I might get in shape once again. Fine. So we start with the AK, that is acute kidney injury. As far as AK is concerned, there are two types. I mean, two things you need to consider. One is the serum creatinine, and second is the urine output. Both these things has to be considered. So as far as the serum creatinine is concerned, we have three different stages of AK. So the stage 1 AK is what we refer to as the definition of AK actually. But in that we have the stage 1 AK. So that's what we call it as the definition of AK. As far as stage 1 AK is concerned, any rise in serum creatinine by at least more than 0.3 milligrams per deciliter over a period of 48 hours, that I can write 2 days, within 2 days, or any increase in serum creatinine by more than 50%, that is more than 1.5 times from the baseline within 7 days, within the last 7 days, within the last 1 week. So this is number one. And apart from that, urine output based definitions are also there, where if the urine output is less than 0.5 mLs per kilogram per hour, as I told you in the previous sessions, this is also the definition of oliguria in the ICU. So even though your definition of oliguria in reality is typically less than 500 mLs per day, any urine output less than half liters per day is a definition of oliguria, but nevertheless in ICU settings and in reality, so anything less than 0.5 ml per kilogram per hour is considered to be oliguric, and anything more than or equal to 1 ml per kilogram per hour is a completely normal output. 0.5 to 1 ml, okay. I mean, especially in ICU settings, I'm okay with that. 0.5 and above, I feel like that's the target urine output that I need to know. So 1 ml is actually normal. So anything 0.5 ml to 1 ml per kilogram per hour is okay when I'm in the ICU. So at least the patient is getting some urine output. I can be happy with that. So the target urine output will be more than 0.5 in ICU. Anything less than 0.5 is oliguric and absolutely non-desirable in critical care settings. So this is definitely an acute kidney injury only for sure. So, and how long? At least for more than 6 hours. At least for more than 6 hours. So this is the first definition, also referred to as stage 1 AK. As far as stage 2 AK is concerned, so here the increase in the creatinine is going to happen by at least 2 to 3 times. Maybe to be precise, it's 2 to 2.9 times. That's what the textbooks will tell. But for simplistic reasons, I can keep it 2 to 3 times the upper limit of normal. That happens in a period of 7 days. We know that. And if the urine output is less than 0.5 ml per kilogram per hour, which means oliguric, but persistently oliguric for more than 12 hours. So that is the definition of stage 2 AK. As far as the stage 3 AK is concerned, so any increase in serum creatinine by at least more than 3 times the upper limit of normal in the last 7 days. Not upper limit of normal, I can tell the baseline, more than the upper limit of normal, which is a wrong statement. Even though I told it by flow, I can call it as the baseline. From the baseline creatinine, if it is more than 1.5, stage 1, 2 to 3 times, stage 2, anything more than 3 times, it is stage 3 AK. Or if the patient is having increase in serum creatinine, abruptly the serum creatinine becomes more than 0.4, increase to more than 4. Serum creatinine has abruptly showed up. It was a normal value previously, but suddenly the serum creatinine become more than 4 milligrams per deciliter. So that abrupt rise in creatinine from normal value to serum creatinine more than 4 can be considered as a stage 3 AK. Or if the EGFR decreases, sudden decline in the EGFR to the absolute value of less than 35 ml per minute per 1.73 meters square. So if the GFR goes to less than 35 abruptly, So that can also be used as a criteria for defining a stage 3 AKA. But remember, this is applicable usually only for children. For adults, we don't use this. So in adults, we use creatinine-based definitions only. EGFR-based definitions are not very useful in adults. In fact, for many AKA patients, creatinine is the key usually. But for CKD patients, as I told you, EGFR is the key for staging and diagnosing. But for AKA, it's always the creatinine. That's going to be the most important. So these are the two things that you need to know as far as exams and reality is concerned. And similarly, if the patient is having severe oliguria, what do you mean by severe oliguria? If the patient is having urine output of less than 0.3 ml per kilogram per hour, and if it's persisting for more than 24 hours, or if the patient is completely anuric, no urine output, and that is persisting for more than 12 hours. In ICU, I mean, leave the definitions of anuria. In ICU, I believe that anuria means no urine output for the last 12 hours. So this is what I mean by anuria. So whenever the patient does not get urine output at all, not even a single drop of urine, that's what I'm going to call it as an anuria. But nevertheless, there are multiple definitions of anuria in physiology textbooks: less than 100 ml per day, less than 50 ml per day. So depending on the situation. So I don't want this anyways. I don't really care about all this stuff. So in my ICU, whenever the patient does not get even a drop of urine, no urine output for more than 12 hours, that's significant kidney injury, and that's stage 3 AKA, completely anuric for 12 hours or more. So these are the 3 stages of acute kidney injury, and the definitions are really, really, really important, asked in many different types of exams. And remember, if somebody asks you whether GFR can be used in AKA or not, GFR can be used in AKA or not, answer is no. You cannot use GFR in AKA. There are multiple reasons why you cannot use GFR in AKA, because to make, first of all, creatinine should be stable. Only when the creatinine is stable, and you know this is the creatinine of the patient, and it's going to be stable for a variable period of time, at least maybe for a week or a month. If you know that, then only you can calculate the EGFR. But in the setting of AKA, creatinine is going to be extremely dynamic, and it's going to increase, then it can fall, and again it can increase depending on the background insult. So we can't really predict the GFR. GFR is also going to be up and down. So there's no fun in telling GFR. I mean, to tell the GFR, first of all, the creatinine should be stable. That's very important. That's what the many formulas, which we discussed already in the previous sessions, are telling you. The creatinine should be stable to tell it's a to tell a particular GFR. Creatinine should be in steady state. So in AK, it's impossible to tell the GFR. You can tell the GFR by formulas, but it will not be accurate. It's impossible to accurately reflect the GFR. And so do not use GFR in AK. It's always the creatinine. So whenever you talk about acute kidney injury, so there are some types of acute kidney injury based on the pathophysiology. This is where it gets tricky, because there are so many causes, so many things. Remember, there are 2 things where nephrologists are concerned with. So nephrology is bread and butter, AK and CKD. Transplant, yes, but not all nephrologists will be a transplant nephrologist. Very few nephrologists, especially it needs a huge experience as well, maybe transplant nephrologists. But their bread and butter basically is AK and CKD. And probably the treatment related to AK and CKD is dialysis. So these are the 3 things that are bread and butter for any nephrologist. So they know everything about this AK and CKD, and they know in and out. So how much to discuss is the key here. And at the same time, transplant is a huge area once again. And again, the idea to discuss for a NEET PG aspirant, or probably even for a postgraduate, is quite difficult in my view, because there is too much in transplant. I worked in transplant unit for almost 3 months, the renal transplant unit. But I worked more in a bone marrow transplant unit for almost 6 to 8 months. I worked in a BMT unit, but in renal transplant unit, I just worked for maybe around 2-3 months. But the amount of workup they do and the amount of things to be known in a transplant setting is, is like Himalayan. Like you need to know too much. So, but nevertheless, what I wanted to discuss in this particular course is like whatever you want to know, and not what I know. So there is a difference between what I know and what you want to know. So I'm going to tell only what you need to know. So first take that point into your mind seriously. And as far as the types of AK are concerned, I generally divide this AK into a pre-renal AK based on pathophysiology. And then we can divide into something called an intrinsic renal AK. And then probably, you know very well, we have something called a post-renal AK, post-renal acute kidney injury. As far as prerenal AK is concerned, we know it is due to some hypoperfusion, low volume status, low effective arterial blood volume. Something is causing the hypoperfusion, the kidney is causing a prerenal AK. So prerenal AK, by definition, it's contributing to approximately 30% of the cases of AK. As far as postrenal AK is concerned, it's usually due to some sort of obstruction. We know that, so it contributes to approximately 10% of the acute kidney injury. As far as intrinsic renal AK is concerned, you can once again divide into acute tubular necrosis, which is the one that contributes to 50% of the cases, which means usually the most common reason for acute kidney injury will be acute tubular necrosis. ATN will be the usual reason for kidney injury. If you take these four things, that pre-renal, acute tubular necrosis, and post-renal, so they together contribute to almost 90% of the acute kidney injury. So you have only remaining 10% that is contributed by other things. For example, you have acute interstitial nephritis called as allergic interstitial nephritis, very negligible, not a very common case to see. And you have some vascular problems, especially the macrovascular problems like atherosclerotic disease, or probably vasculitis causing like polyarteritis nodus, or some thrombotic microangiopathies, DIC, preeclampsia will come under these vascular problems. Then probably you can think about some glomerular causes, glomerulonephritis, acute glomerulonephritis. So all these things, in fact, glomerular causes are extremely rare in practice. We don't really get. That's why I told you, even though we discussed substantially about glomerular disorders in the last 6-7 hours, but nevertheless, in reality, it's important for exams because that's very basic for you to know it, because it starts from a secondary pathology. That's why they ask so many questions. But in reality, like we don't really see that much of glomerular disorders. So that's something which is very important. So all these causes, if you see, you're going to have only the remaining 10%. So allergic interstitial nephritis, vascular causes, glomerular causes, all these things will contribute to another just 10% of the cases of AK. So that's the reason why whenever you take any textbook, usually they will try to differentiate between this pre-renal AK and the acute tubular necrosis. So this is what you have to differentiate. So that's the biggest challenge, because these two are the major chunks in reality. So acute tubular necrosis and pre-renal AK. So that is the reason why any nephrology textbook, or probably any basic level textbook or any medicine textbook to start with, they will always ask you how will you differentiate between a pre-renal AK versus a acute tubular necrosis, because these two are extremely common. Together they contribute to almost 80% of your acute kidney injury cases. So that's why it's very important to differentiate these two in reality. Post-renal, you can write separately, but I believe that post-renal AK is very easy to diagnose because it's obstruction. All you just need is a simple ultrasound to make a diagnosis. So you don't really need anything else to diagnose a post-renal AK. So it's all about obstruction. So ultrasound itself is enough to diagnose this obstruction in reality. So not a problem at all. So how will you differentiate between this pre-renal AK and acute tubular necrosis? AN, you do have some, peculiar findings. Vascular causes will have some peculiar findings. Glomerular causes, we've already discussed. I'm not going to discuss any glomerular causes. We already done enough with this acute glomerulonephritis. So don't want to discuss about that. How will they behave? We know that already. But to know this pre-renal versus ATN, let us take a glomerulus first. So what will happen in a glomerulus and a tubule? So we do have this afferent arteriole and an efferent arteriole. So this is an image which you have drawn multiple times in the past. So this is an afferent arteriole, this is an efferent arteriole. And there are a lot of conditions that produces hypoperfusion to the glomerulus, or we can write as low effective arterial blood volume. Both are correct, either low perfusion itself or low effective arterial blood volume. So whatever may be the case. So there are many conditions that produces low perfusion to the kidneys or altered perfusion to the kidneys. For example, I can write certain examples here, like maybe NSAIDs. NSAIDs block the prostaglandin production. Prostaglandins are very, very important for the afferent arteriole to produce vasodilation. If there is vasoconstriction of the afferent arteriole, if there is no production of prostaglandins because of NSAIDs, you're going to have a reduced renal perfusion. And of course, your ACE inhibitors and ARBs can produce reduced renal perfusion by the mechanisms which you have discussed already multiple times in the past. And at the same time, there are many other conditions like contrast agents, because in contrast-induced nephropathy, one of the characteristic thing that happens in contrast-induced nephropathy is the vasospasm. That is the vasoconstriction. You give a contrast, the kidneys go for vasospasm. The vessels vasoconstrict. That's what is going to happen in a contrast. So you need to know about the contrast. And apart from that, there are many other drugs like calcineurin inhibitors, cyclosporin and tacrolimus. Even though cyclosporin and tacrolimus are toxic to the tubules and interstitium also, but one of the mechanisms how calcineurin inhibitors like cyclosporin and tacrolimus cause renal injury is this vasospasm. So by altering the renal perfusion, they can do that. And second thing is hypercalcemia. Remember, hypercalcemia or high calcium levels in the blood is directly toxic to the distal nephron, producing many conditions like nephrogenic diabetes insipidus, interstitial problems, polyuria. And one more problem that calcium does is this severe vasoconstriction and probably causing reduced renal perfusion, which can result in development of pre-renal type of an acute kidney injury. And apart from that, there is one more important condition that is called hepatorenal syndrome, that is called HRS. So that's very important again. So what happens in HRS is very simple. There will be a splanchnic vasodilation in any cirrhosis patient or any patient with severe portal hypertension. So what's going to really happen is something called as a splanchnic vasodilation, where the intestinal vessels would have vasodilated, but the kidney vessels would have vasoconstricted. So that's a renal vasoconstriction and a splanchnic vasodilation. This is due to inappropriate production of nitric oxide, and there's a lot of adaptive mechanisms that happen because of cirrhosis. The kidneys may go for underperfusion and they can develop hepatorenal syndrome. So remember, HRS is typically a pre-renal disorder. It is a pre-renal AKI for sure. And I'll tell you how to diagnose an HRS in some time. You need to know a lot of things to diagnose hepatorenal syndrome in the first place. And apart from that, you can get this with probably sepsis. Sepsis is another condition that produces vasoconstriction, which is typically pre-renal in nature, which I'll come back to that in some time. But more than that, I can write here also. There is something called a reduced effective arterial blood volume. There are conditions produce reduced EABV, effective arterial blood volume. Even though the overall blood volume is okay, the amount of blood that is reaching the kidneys may be low. So what are the conditions that produces reduced effective arterial blood volume? So number one, hypovolemia. Of course, there is a lower volume in the body, so the effective arterial blood volume also will be low. And in patients who are having a cardiac failure, cardiac issues, because of the low cardiac output. So that is one reason. And apart from that, there are some conditions which produces lower oncotic pressure. Because of lower oncotic pressure, there will be more fluid outside the vascular compartment and there will be lesser fluid within the vascular compartment. And that's what happens in certain conditions where there is severe hypoproteinemia and hypoalbuminemia. As a result of that, you might have a lower perfusion to the kidneys because of the lower amount of blood that is present within the vascular compartment. That is nephrotic syndrome and cirrhosis. Nephrotic syndrome and cirrhosis. That is due to lower oncotic pressure basically. And apart from that, there could be severe peripheral vasodilation. It can happen in any distributor type of shock where the blood gets pooled in the periphery and unwanted areas and they don't reach the central circulation properly, so that the amount of effective arterial central blood volume will be low to perfuse the organs. So that's why the best example here is going to be sepsis. So these are some of the examples where you can get a lower perfusion and a low effective arterial blood volume. So similarly, low perfusion can also happen in certain situations where there can be large vessel involvement. So large vessels of the kidneys may be involved. So large vessels of the kidney involved means you can think about the best example for this I will call it as a renal artery stenosis. Renal artery stenosis itself has many different causes, which we'll be discussing in the subsequent sessions. But you have two causes: atherosclerosis, which is common, and second is fibromuscular dysplasia. We know that. So renal artery stenosis, especially in one situation where they go for severe hypoperfusion, is when the patient is having a bilateral renal artery stenosis plus if the patient is using a AC inhibitor. In this situation, they'll go for hypoperfusion. In unilateral renal artery stenosis, they generally don't go for hypoperfusion, as I told you already. Suppose if you take a kidney on one side, kidney on other side, if you see the aorta that is supplying the kidneys through renal vessels, renal arteries. Now, if you take, this is the ureter that is coming. So if you have a renal artery stenosis on one side, suppose if there is an obstruction on this side, so there is a renal artery stenosis on this side, what happens is there will be reduced renal perfusion to this side, I'm not telling no, there'll be reduced perfusion to these kidneys, surely. So because of that, many patients with unilateral aortic stenosis will have asymmetric kidneys. One side will be small, another side will be normal. So reduced perfusion. And this reduced perfusion is going to activate the RAS system, and they are going to result in increased blood pressure, of course, and more renin-angiotensin system activation. And at the same time, the blood that is about to go to this kidneys will not go, and instead they will get shunted towards this normal kidney only. So again, that is due to autoregulation. So this kidney will receive actually more perfusion. Because this kidney is receiving more perfusion, they'll be actually producing more urinary sodium compensatory through this kidney. So whenever the perfusion increases, the filtration of sodium will also increase. So there will be more urinary sodium that will be produced from this kidney. So this RAS that is hyperactivated here, that is trying to increase the urinary sodium, that is trying to increase the sodium reabsorption, will be counterbalanced by the perfusion related high urinary sodium. This is what we refer to as a pressure natriuresis. Everyone would have heard about that. That's called a pressure natriuresis. So more pressure itself will filter more sodium, and more sodium filtration will not result in edema. That's why if you see essential hypertension patient, so take an essential hypertension. So many patients we see with the BP of 180, 190. So even with significant RAS elevation, they don't really get hypervolemic state. One reason why they don't develop hypervolemic state is because of the pressure natriuresis. That itself will actually excrete more sodium. So this is a balanced scenario. So the patient will not get volume overload state. No volume overload state for sure. But on the other hand, if the patient is having a bilateral renal artery stenosis, this is a problematic entity. If you have a bilateral renal artery stenosis, for example, this side you don't have proper perfusion, this side also you don't have proper perfusion, and you have the ureter for namesake here. But here if you see on both the sides there is reduced perfusion, and both the sides there will be severe activation of RAS, and both sides they will try to increase the increase the sodium reabsorption, and because of the same they will move towards volume overload state. And that is also one reason why bilateral RAS is usually associated with very commonly flash pulmonary edema and death. They can go for sudden severe flash pulmonary edema. That is because of the too much of sodium overload that is happening in these particular patients. And again, if you give ACE inhibitors, that's going to be a disastrous scenario, where I told you in the previous video itself, because of autoregulation that is happening, angiotensin 2 is very, very important for autoregulation. If you block the AT2 mediated this regulation, and everything will collapse, and the patient will go for complete hypoperfusion, and they'll go for severe renal failure and rise in creatinine and hyperkalemia. That's what is going to happen. So RAS is one condition where you need to know, especially if it's bilateral and if the patient is having given with ACE inhibitor, so they might go for severe hypoperfusion of the kidneys. But in unilateral RAS, it's not a problem, because unilateral RAS, one side is actually compensating, and they're having a hypoperfusion only on one side, but increased perfusion on the other side. That is the reason why we use this captopril assay also. I think, yes, last time you would have studied something called a captopril based scintigram we do. So what captopril based scintigram does is, captopril will block the angiotensin 2 mediated autoregulation. So what really happens is, here the angiotensin 2 becomes very, very important for autoregulation. So whenever you block the angiotensin 2 activity by giving captopril, this side's low perfusion will actually become more severe, and this side's hyperperfusion will become more also. So this difference that is already existing between the two kidneys, this perfusion difference, will get magnified when you give captopril, and that can be captured in an image in nuclear scintigraphy, and that's what we call as a captopril scintigraphy, which is very useful in the setting of a renal artery stenosis. So in unilateral renal artery stenosis, it's very, very helpful. In bilateral RAS, it's of little help, But in unilateral renal artery stenosis, this captopril-based scintigraphy is extremely helpful because it magnifies and augments the difference that is already there and shows which kidney is actually having more perfusion, which kidney which is not having perfusion. So that's what happens when you give a captopril-based scintigraphy. And captopril-based scintigraphy may be useful for treatment monitoring also. Suppose if you are given some treatment to open up this vessel, after that you can see whether the perfusion is happening or not. So in that setting also captopril-based scintigraphy may be useful, even though we don't really treat renal artery stenosis very aggressively, especially if it's unilateral. But just for namesake, I told you. But nevertheless, renal artery stenosis is one very important macrovascular cause, a large vessel cause that causes a reduced renal perfusion. Apart from that, another condition which can reduce the renal perfusion is aortic dissection, especially if it's happening in the descending aorta and extending into the like abdomen. So they can result in reduced renal perfusion. In bilateral case, what to do? In bilateral case, depending, there are some indications to treat. Either you start treating like a CKD if the patient presents a CKD, or if the patient has recurrent flash pulmonary edema, or there are some definitive indications which I'll tell you later on, where you can do this kind of stenting or some renal intervention can be done. But remember, it's not as simple as a PCA, like what you do in the heart. In the heart, you do a stent and come back. It's little simple. But in the kidneys, the outcomes are not that great. Even if you stent this kidney or if you stent these vessels which have gone for RAS, that's like not having a good prognosis. But remember, there is one disease even with RAS that has an excellent prognosis, that is fibromuscular dysplasia. In fibromuscular dysplasia, we don't even put a stent. We actually just do something called angioplasty. Just go there and dilate with the balloon. Once you dilate with the balloon, you come back. That's all you need in fibromuscular dysplasia. 100% cure rate, almost near 100% cure rate, just with angioplasty in the setting of fibromuscular dysplasia, which happens in younger individuals. But fibromuscular dysplasia happens in the middle third. Usually, it will not happen at the bifurcation point. But as far as your atherosclerotic RAS is concerned, it's actually it's a common type, but it's quite difficult to treat. And again, stenting, angioplasty, nothing has shown to improve the outcomes that much as far as atherosclerosis is concerned. But fibromuscular dysplasia type of RAS has a different outcome. That I'm not talking about that. I'm talking about the most common type, that is the atherosclerotic type of renal artery stenosis, which is very difficult to treat. Even with interventions, even if it is bilateral, I don't really think they are that beneficial, even though there are some definitive indications which I'll tell you later on, but they are not that beneficial. And aortic dissection, on the other hand, can produce reduced renal perfusion, which can result in activation of RAS system, and you can get a renal failure and related stuff in aortic dissection as well. At the same time, patients with something called abdominal compartmental syndrome, I will talk about that later on, abdominal compartmental syndrome. But how much to tell about abdominal compartmental syndrome is again a key here. So whenever the intra-abdominal pressure exceeds 20 millimeters of mercury, there are various ways to measure the intra-abdominal pressure. In reality, in exams, what kind of case you're going to get? You're going to get a case probably who's having an acute abdomen, or probably a post-op case after an abdominal surgery, and the patient is having a rising creatinine, oliguria, but the patient is having a very tense abdomen. You cannot even press, or very rigid abdomen. So in that setting, probably I can think about abdominal compartmental syndrome. If they ask you the first step, what do you do in abdominal compartmental syndrome? I just wanted to decompress the bowel first, because whatever fluid in the bowel, if it comes out, at least it can relax the abdomen a little bit or reduce the pressure within the abdomen a little bit. So first thing that you need to do after thinking about a probable case of an abdominal compartmental syndrome is put a nasogastric tube. So that's the very common question that you get in exam. So anyways, nevertheless, if they ask you the definition of abdominal compartmental syndrome, due to tense abdomen, that high pressure in the abdomen itself can reduce the perfusion to the kidneys, so that you can result in pre-renal failure. So very, very important. Intra-abdominal pressure more than 20 millimeters of mercury with a oliguria. In a patient who is having oliguria and a rising creatinine, you can think about a abdominal compartmental syndrome. And certain vasculitis like Takay's arteritis and other large vessel vasculitis can produce large vessel problems, and they can produce reduced perfusion to the kidneys, but not very important. If I tell vasculitis, you will be confused. Remember, you have polyarteritis nodosa that causes intrinsic renal failure. You have small vessel vasculitis that produces glomerulonephritis and renal failure. You have large vessel vasculitis that typically produces pre-renal failure. So to start with, if you want to really know what vasculitis will cause what renal failure, first of all, you need to know that small vessel vasculitis will produce glomerular nephritis only, and you know what you expect in glomerular nephritis. And typically, medium vessel vasculitis like Polyposis nodosa will produce vascular type of intrinsic renal failure only. When you take a large vessel vasculitis like Takayas arteritis or a giant cell arteritis in late stages, they can produce pre-renal type of renal failure only. So you need to know what are the three things that you're going to see typically. So remember, the blood pressure will be quite variable depending on what is the cause that you're encountering. Even though in all these situations there is a low renal perfusion, the blood pressure may be quite variable. For example, in patients who's having a hypovolemia, cardiac problems, cirrhosis, sepsis, they might be even in shock, except in nephrotic syndrome. Many of these patients may have a shock. For example, patient in nephrotic syndrome may have a normal BP or hypertensive. Other conditions like hypovolemia, cardiac problems, cirrhosis, sepsis, they might have a low BP and a shock-like scenario. In patients who are having a large vessel involvement, again, majority of the patients with large vessel involvement may have a hypertension because, you know, RAS will produce hypertension, and dissection may produce hypotension and shock. We have discussed already in the cardiology. Abdominal compartment syndrome, on the other hand, can produce hypertension once again. And again, these causes can produce normal BP or hypertension or hypotension. So once again, it's not like when you suspect a pre-renal cause, your BP will be low or high or normal. So one thing you need to know is if you have a pre-renal cause, BP is highly variable depending on the cause. But in exam, when you will think about a pre-renal case, whenever you have a patient who's a hypotensive patient. So that's what the examiner wants basically. So in exam, the examiner will be a little liberal. He'll be giving a low BP always if you want to diagnose a pre-renal failure. That's very important. But nevertheless, in reality, the BP is highly variable. You cannot tell it's a pre-renal or intrinsic renal failure based on the blood pressure alone. That's very important. And at the same time, even though I told you hypoperfusion is the reason for developing a pre-renal AKI, there are some patients who's having a persistent or prolonged hypotension or hypoperfusion, or if they're having a sudden and severe hypoperfusion, they can actually progress towards a ATN. They can progress towards acute tubular necrosis. So it's not like hypoperfusion will always lead to pre-renal AKI only. Patients who are having a persistent or a sudden severe hypoperfusion can usually go for a acute tubular necrosis as well. So what are the conditions that produce acute tubular necrosis? First of all, you need to know any severe ischemia. I'm not talking about just hypoperfusion. Any severe hypoperfusion or a life-threatening hypoperfusion, ischemia can result in development of acute tubular necrosis, not a pre-renal failure. So the characteristic examples, sepsis, especially if the patient is in severe septic shock, they can progress towards acute tubular necrosis, or patients who are having a severe contrast-induced nephropathy can result in development of severe ischemia to the kidneys, resulting in acute tubular necrosis. And at the same time, if the patient is having a free hemoglobin or a myoglobin in the blood. So you know what are the conditions that produces free hemoglobin or myoglobin in the blood? Everyone knows that. Free hemoglobin or myoglobin in the blood means you're dealing with the hemoglobinuria, which happens in typically intravascular hemolysis. Extravascular hemolysis usually does not produce free hemoglobin. Intravascular hemolysis typically produces more free hemoglobin. And second is you can get free myoglobin in rhabdomyolysis, RBM, rhabdomyolysis. So the reason why they produce acute tubular necrosis is multiple. Number one, the hemoglobin can deposit directly on the tubules, can cause direct tubular damage. And similarly, myoglobin can directly deposit on the proximal tubules and they can cause a direct tubular damage. At the same time, they can produce severe vasoconstriction. This is one area where you can encounter severe vasoconstriction and you can develop a acute tubular necrosis because of severe ischemia. And apart from that, if the patient is having a cardiac arrest, so after cardiac arrest, if you get a renal failure, very likely it will be an acute tubular necrosis. I don't think in cardiac arrest, you will have a very small hypoperfusion of the kidneys. It's like the kidneys are stunned completely. They don't receive blood supply for a long time. So they can get an ATN after cardiac arrest. It's a very severe ischemia. Or for example, if there is a AAA rupture, abdominal aortic aneurysm rupture, once again, it's not a very simple thing. This abdominal aortic aneurysm rupture produces severe hypoperfusion. At the same time, they produce abdominal compartmental syndrome like picture where this blood will come get will actually compress on the renal vessels and they produce severe hypoperfusion. Siddharth is asking what will happen in mismatched blood transfusion. In mismatched blood transfusion, you really won't get pre-renal, you'll get a acute tubular necrosis only. That is because of the free hemoglobin once again. That's a mismatched blood transfusion is actually intravascular hemolysis only. So that's what happens. Even though some element of extravascular hemolysis will be there, but it's a classic example of a intravascular hemolysis. So again, you'll have a free hemoglobin and same problem. Okay. Or you can get with many other conditions. Many toxins can produce acute tubular necrosis basically. Toxins can produce acute tubular necrosis. What are the toxins that can basically result in acute tubular necrosis? Like for example, many drugs can produce acute tubular necrosis. That is the reason why ATN is quite common, 50%. The reason is because so many causes are there. Anything can produce ATN. So many drugs can produce. I will believe that the usual drugs that we encounter in reality that causes acute tubular necrosis are aminoglycosides. Please understand the fact in typical aminoglycoside related toxicity, the patient will be non-oliguric. And at the same time, you usually get around day 4 to day 7. So this is the classic timing where you get a acute kidney injury in aminoglycosides. Non-oliguric renal failure at around day 4 to day 7. Classic aminoglycoside related kidney injury. So you need to be very clear about that. So drugs like amikacin, gentamicin have more renal toxicity compared to the other aminoglycosides, but nevertheless, any aminoglycoside can cause acute kidney injury. Non-oliguric, day 4 to day 7, which is really, really important. And apart from that, another routine drug which is severely nephrotoxic can cause renal injury is vancomycin, which I'll never ever forget. Vancomycin, I've seen so many cases of vancomycin nephrotoxic. That's why these two drugs, very, very importantly, you need to do therapeutic drug monitoring. TDM. TDM is definitely needed for these two drugs, where we always see the trough levels, and based on the trough levels only, we give the next dosing. So dosing should be based on the trough levels. And of course, we do measure the peak levels also to see the efficacy. But remember, why you see the peak levels? To see the efficacy. Why you want to know the trough levels? To detect whether you can give the next dose or not, so that to avoid the kidney injury. So that's why you see the trough levels. But nevertheless, these are the two drugs where very commonly in my hospital where we employ the therapeutic drug monitoring. So vancomycin levels, we always measure. It's a very routine thing. Suppose if you don't know whether the patient will have vancomycin nephrotoxicity or not, suppose if the creatinine is maybe 6 milligrams per deciliter, can you give vancomycin? Answer is yes or no. Can you use vancomycin or can you use aminoglycosides? If you have a serum creatinine of 6 at presentation, can you give? Yes or no? Actually, the answer is yes. You can give vancomycin, not a problem at all. So initial first dose of vancomycin, you don't have any contraindication. So the first dose usually we give is 1 gram loading dose of vancomycin. The usual dose of vancomycin is 1 gram BD. This is the usual dose of vancomycin that we use in adults. As far as the kidneys is normal, this is what the dose I'm going to give. If the trough levels, peak levels, everything is okay, I'll be giving you 1 gram BD dose of vancomycin. That's a standard dose of vancomycin. But if you don't know the future kidney status and currently the patient is coming with a high creatinine, you still can proceed ahead with the first dose of vancomycin. Not a problem. The typical dosing protocol in resource limited settings that we generally tend to give is 1 gram IV 48 hourly. This is the usual dosing protocol that we follow in resource limited settings. That's what we advise to do in peripheral settings, 1 gram IV every 2 days. So this is the dose we use if patient is having a severe renal failure and we don't know the kidney state. So in that setting, you can go for 1 gram every 48 hours, but that's not right. Always vancomycin should be given based on the trough levels only. So to avoid any element of nephrotoxicity. And another drug that is very important, which I've seen so many patients suffering from nephrotoxicity because of this drug, is amphotericin B, which is a very, very important drug. Again, so even though we use the liposomal forms of amphotericin B, because the amphotericin B is very toxic to the kidneys, especially the distal nephron, they will damage the distal nephron. They will produce distal RTA also. I have told you maybe some time back. So I think RTA we covered, I guess. Have we covered? I think in the ABG itself I covered RTA, renal tubular association. So I don't think we need to discuss this anymore. Yes. So amphotericin B, I have told it causes distal RTA because it's a very toxic to distal nephrons because it induces pores, and since the distal nephron is actually a little acidic also, and that environment is very conducive for this amphotericin B to induce pores in the membrane, and they can produce serious toxicity to distal nephron. So creatinine might go skyrocket after giving amphotericin. That's why we use that liposomal amphotericin B, which is less toxic compared to the original amphotericin B, but nevertheless they are very important in causing your kidney injury. And apart from that, there is another drug which I have mentioned with great intent, that is tenofovir disoproxil fumarate, on any form of tenofovir, but TDF is having a higher risk of producing distal renal tubular acidosis because it's also a drug that is very toxic to the proximal tubules. So they can result in AK. So TDF is a very important drug in hepatitis B. TDF is a very important drug in HIV, where the only one problem that we face with TDF is this nephrotoxicity. It's a dose-limiting side effect, and apart from that, it's an excellent drug. One of the few NRTIs that has like very low side effects and excellent efficacy. But unfortunately, this is the only dose-limiting side effect, that is the nephrotoxicity. And apart from that, we have many other drugs which we don't really use that often, like maybe cisplatin. I mean, this is a very common drug in oncology part, but in routine day-to-day practice, we don't use this drug very often. Cisplatin can cause that, and you can get with foscarnet, which is an antiviral drug. We know that in certain patients with cytomegalovirus, we used to give foscarnet, and you can get with one more drug, pentamidine, not very commonly used drug as well. You can get with pentamidine, and probably some patients with IVIG. I have experienced some forms of AK. You can get with IVIG, and some solutions we use HES, hydroxyethyl starch. So this also can result in development of AK. But as far as I know, in exams, these are the 4 drugs that you need to know: samnoglycosides, amphotericin B, vancomycin, and tenofovir disoproxil fumarate. And apart from drugs, we have some pigment nephropathy. Whenever I talk about pigments, it's always free hemoglobin and myoglobin once again. So that's why I told you free hemoglobin and myoglobin have multiple different pathophysiologies, how they cause ATN. So pigment nephropathy means we talk about a free hemoglobin or a myoglobin. Now, once again, we know it's either an intravascular hemolysis or probably a rhabdomyolysis. That's what we're talking about. Then it could be due to crystal deposition. Some crystals may be deposited. For example, crystals in the sense it could be due to uric acid crystals. It could be due to calcium phosphate crystals. It could be due to acyclovir crystals. And it could be due to methotrexate. It could be due to indinavir. It could be due to phosphate load, sodium phosphate load. And in exam, very notorious question is this phosphate load. Very notoriously they will ask in exam, phosphate load causing phosphate nephropathy. So usually what is the history they will give in exam is the patient has gone for colonoscopy. It's a completely unrelated history, isn't it? Colonoscopy. After that, the patient will develop an AK, and the serum creatinine is 6.4. So it's something, like you can imagine, like colonoscopy, after colonoscopy, you're having creatinine of 6.4. You'll be like, like thinking about what's happening here. I mean, they will also give initially the patient had a serum creatinine of 0.8 before colonoscopy. Before doing a colonoscopy, serum creatinine is 0.8. And after doing a colonoscopy, within some 3-4 days, patient came with weakness. You check the creatinine, it is 6.4. And they'll ask you, what is the next step? If they ask you what is the next step, what you will do? Next step to diagnose what is the problem. What is the next step in establishing the diagnosis? What is the next thing you need to do? What is the next step? Okay, check the serum phosphate. That's more important. Usually normal serum phosphate is somewhere around 2.5 to 4.5 milligrams per deciliter. This is a normal serum phosphate in SI units, in standard units. But this patient will be having probably a serum phosphate of 13, 14, so this is a phosphate nephropathy. So why is that so? Because during colonoscopy, you would have used some preparations like Coloprep and a lot of preparations, which is nothing but sodium phosphate kind of enema or sodium phosphate kind of preparation that used, where some patients may absorb phosphate too much and results in too much phosphate, causing a acute phosphate nephropathy. So which is common in some patients who are susceptible. So phosphate load is also very important, which can produce calcium phosphate kind of crystals, which can result in development of acute phosphate nephropathy. These patients very commonly we take for dialysis because calcium phosphate is something which is very difficult to eliminate. So always take for dialysis. And we have some other conditions like monoclonal immunoglobulins. Monoclonal immunoglobulins can produce ATN, like light chains, which can produce AL type of amyloidosis. This light chains, which deposit typically on the proximal tubules, can result in development of severe kidney injury and acute tubular necrosis. So apart from this, I think I've left out a lot of causes. Like so much of causes are there, and really, like you can't tell how much is there. So that's why ATN is extremely common in reality compared to what you see. So you can see here the tumor lysis syndrome, hemolysis, like for example, Plasmodium falciparum, mismatched blood transfusion, or myoglobin, that is rhabdomyolysis, calcium phosphate, phosphate load, acyclovir, indinavir. You have multiple drugs that you use commonly in clinical practice. Then sepsis is extremely common, and contrast when used after radiology contrast after cardiac arrest or a severe cardiac failure. So many conditions are there. That's why I told you rightly that ATN is the most common type of renal failure that you're going to encounter, 50% basically. So pre-renal versus an acute tubular necrosis. So how to differentiate basically. So I mean, why it is again confusing, why you need to really differentiate these two disorders is because many times I told you if it's pre-renal is persistent and severe, or if hypoperfusion is persistent and severe, you can result in acute tubular necrosis. So based on history alone, it's really difficult to diagnose whether it's a pre-renal or an acute tubular necrosis. Plus, at the same time, there might be certain patients who are at risk of developing a acute tubular necrosis, like patients who are already having diabetes, patients already taking NSAIDs. These patients, even small kind of hypoperfusion, they cannot tolerate, because even small hypoperfusion in a patient who's already susceptible, or in a patient who's already having a damaged kidney, might easily develop an acute tubular necrosis. That is why you have to note that point also. It's not like always certain cause will produce pre-renal only, certain cause will produce ATN only. If a patient is, suppose if I am getting the same insult, I'll develop only a simple pre-renal and I'll move on. But certain patients who are susceptible or already having a renal damage, if they are going to get a small insult of hypoperfusion also, they might develop an acute tubular necrosis. So it's not like it's fixed that these causes is pre-renal, these causes are acute tubular necrosis. Even though you can differentiate for theoretical reasons, but practically it's very difficult to differentiate. That's why we have so many things or parameters to differentiate. But still, most of them are not foolproof. It's always a clinical judgment that will tell you. But ultimately, the treatment is very simple. But differentiating is tough at the same time. You need a lot of the basic parameters to know. So for the first thing, what we need to tell is that your sodium and urea. So that's what we're going to talk about. So first, in a hypoperfusion state, the one thing that will be activated is renin-angiotensin-aldosterone system. This renin-angiotensin-aldosterone system is going to also activate the ADH. By definition, please understand, in a pre-renal failure, the kidney function is normal, or I can write the tubular function by default is actually normal in a pre-renal failure. This is a thing about pre-renal failure we're talking about. In a pre-renal AKI, the tubular function by default is basically normal in a pre-renal failure. So which means they respond very well to this RAS and high ADH. This RAS, of course, is going to increase the sodium reabsorption, and they are going to increase the solute reabsorption, and at the same time this ADH is also going to increase water reabsorption. ADH is also, RAS and ADH together also tries to absorb a lot of urea and other solutes. So sodium, urea, water, all these things will be reabsorbed more as far as your pre-renal failure is concerned. So this sodium reabsorption, don't think it will cause volume overload, because already patient is having a hypovolemic state, low perfusion by definition. So they usually does not cause volume overload, but they might cause volume overload in certain scenarios like nephrotic syndrome, cirrhosis, cardiac problems, depending on what is the pre-existing volume. If the pre-existing volume is already low, then they will try to restore normal volume, so the volume overload will not happen. The pre-existing volume is already normal or more, then they will add on to the volume and they'll produce volume overload. So again, whether it will produce volume overload or not is different. So we're not going to talk about that. But this RAS will try to increase the sodium reabsorption. Of course, the urinary sodium will be definitely low. So if the urinary sodium is low, you will also have a low fractional excretion of sodium. That is, FeNA will also be low. And the second thing that you need to know is that urea excretion is increased. So the fractional excretion of urea will also be low. And third thing is the water absorption is increased, so the water excretion will be low. So there will be increased concentration of the urine. The patient will be passing highly concentrated urine. The urine osmolality will be high. At the same time, the specific gravity of the urine also will be a little high. So it will be usually more than 1.030. So these are the typical constituents of a pre-renal failure. But the patient may have oliguria. Usually they will have oliguria. Why oliguria? Because you know that these patients are having low perfusion. If they're having low perfusion of the kidneys, how in the world do you think they will not have oliguria? They will definitely have low urine output because of low perfusion in the first place. And next thing what they'll be asking is Bunn to creatinine ratio. So what do you mean by Bunn to creatinine ratio? The blood urine nitrogen by creatinine ratio. You can simply take it as urea in the first place. Urea is a major nitrogenous compound in the blood. So you can assume that in this setting, the urea will be increased. Because the urea is increasing, the Bunn ratio will rise. But creatinine will not rise that much in a pre-renal failure because the tubular secretion of creatinine is okay, not a problem. But there can be a small, mild increase in creatinine. That is because of the low perfusion that is happening at the glomerular level. Because there is low perfusion that is happening at the glomerular level, there might be a mild increase in creatinine. It might not adequately enter the kidneys. So creatinine usually might be normal, or there can be a mild increase in creatinine, which means the net Bunn creatinine ratio will be very high in the setting of a pre-renal AKI. So, but remember, there is a different things that you need to know. For example, if Bunn alone is increased, that is basically called as azotemia. Bunn alone is increased. That is called as azotemia. Azotemia can be symptomatic or asymptomatic, doesn't matter. If blood urine nitrogen is increased, we call it by a term called azotemia. But there is another term called uremia. Basically, when you call it as uremia, it doesn't mean urea elevation. Urea elevation always will produce azotemia, but uremia is a more clinical term. So if the patient is having some clinical features because of high nitrogen, or the patient is having some clinical features, some clinical problems because of the high urea in the body, so that is uremia. So which means I can tell that uremia is more of a clinical syndrome rather than just increase in the urea values. But azotemia is more value based. If anywhere if your Bunn is high, the blood urine nitrogen is high, there will be azotemia. So there are two different things. So azotemia is more of a value based term, but whereas uremia is more of a clinical term. So you need to understand that. Similarly, if they ask you how will you calculate the Bunn, blood urine nitrogen, typically in our setup there is complex calculations are there, but in reality, take the urea and divide by 2, you get the Bunn. It's around 2.1 to 2.214. But overall, if you see, if you half the urea, you'll approximately get the Bunn, blood urine nitrogen. So that's not a big deal. So in exam, always see the Bunn creatinine ratio, not the urea creatinine ratio. So to get the Bunn, you just divide urea by 2 approximately. Somewhere you get the approximate Bunn at least, blood urine nitrogen. Okay. Fine. So this is all about the pre-renal failure. So now we are going to the intrinsic renal AKI. That is the acute tubular necrosis. Now we are talking about acute tubular necrosis. In acute tubular necrosis, by default, you are actually having a loss to tubular function, which means the tubular function is not there in the first place. And more importantly, if you see the urine sediment in a patient with a pre-renal failure, I don't think there is any need to see the urine sediment here. So it will be typically bland. We call it as a bland urinary sediment. You don't really get any sediment here in patients who's having a pre-renal failure. That's also very important point. I'll tell you why that is important. And as far as acute tubular necrosis is concerned, usually there will be shedding of the renal cells. So which means the first thing to be having is the lost tubular function. Lost tubular function, that is the first thing. So once the tubular function is lost, there is first stage that's called an initiation phase. Initiation phase, the tubular function will be lost. One of the important tubular function is reabsorption of water and concentration of the urine. So the first thing to happen in acute tubular necrosis is a poor urinary concentration, which means patient cannot concentrate the urine. So that is the first thing to happen even in the initiation phase. That's poor urinary concentration because tubular function will be lost. That's the first thing. So once the tubular function is lost because of poor urinary concentration, the patients may transiently even experience a polyuria. So urine output may be normal or even maybe increased. Doesn't matter. That's in the initiation phase. But during this time, the serum creatinine maybe normal or maybe increased, but usually it will start to increase at this phase. Usually it will start to increase by this phase by 0.8 of basic value. It might become around maybe 2 or 3, so it might go to that range. So it might increase a little bit. Just hold on. Okay. Because I have some glitch over here. You're able to see properly, right? So what I am writing. No problem. Okay, fine. Cool. No issues. So usually your serum creatinine starts to rise in this setting. So in initiation phase, but the first thing to happen is this poor urinary concentration because of the lost tubular function. Serum creatinine starts to rise, and that's what is going to happen in the initiation phase. But otherwise, there will be no problem at all. There will be no uremic symptoms. No uremia or azotemia will be there. I mean, even the azotemia can be there, but there will be no clinical features because of that, and there will be no uremia. But there can be azotemia. There can be azotemia. I don't want to write that, but urea can start rising. Nitrogen substance in the blood can start rising. Azotemia may be there, but uremia will not be there. Uremic clinical features will not be there. And at the same time, there will be no dyselectrolytemia. Dyselectrolytemia, which means patient will not develop problems like hyperkalemia. There will be no acidosis as well. So otherwise, the patient will be looking almost okay. But the only problem will be that poor urinary concentration. So that's the first thing. So what is the evidence of poor urinary concentration? The urinary osmolality will be very low. They cannot concentrate the urine. That's the first thing that should happen by definition, by default in this particular situation. So usually, how will you identify? It's very difficult to identify at this stage. So if you pick up this rise in the serum creatinine at the beginning itself, if you pick up this osmolality, then you can try to reverse the cause. But nevertheless here, the treatment is very simple. You just need to stop the offending cause. So there must be some offending cause for 18. 18 is always secondary. There is nothing like an idiopathic acute tubular necrosis. Always there will be a cause. Just try to stop the offending cause. So most of the time it will be completely reversible. You can try, completely you can bring the kidneys back to normal. So no problem at all. This is what happens in initiation phase. Then what happens is, next thing, the sloughed cells, the tubular cells that are sloughed, which are destroyed because just severely injured, will come and get stuck together, and they start getting accumulated in the tubular region. And because of that, your kidneys, might not be able to push this urine out, even though some urine might get trickled out of this obstructed area, but still majority of the glomerular filtrate will not come out. And this accumulation of the glomerular filtrate is going to increase the intraglomerular pressure. IGP will be increased. Because the increased intraglomerular pressure, you will not be able to filter properly, and the filtration process will take a serious hit and will be damaged. So there will be a dramatic decline in the GFR. That's because of severe increase in the intraglomerular pressure. And because of that, there will be too much increase in the serum creatinine and the urea, because now the serum creatinine cannot be filtered, urea cannot be filtered, sodium cannot be filtered. So much of problems will start to happen. Clinically speaking, this phase is what we refer to as something called the maintenance phase. Maintenance phase. During the maintenance phase, one characteristic problem you will be getting, you will be already getting a poor urinary concentration. Doesn't matter. You will be having all the characteristic features of 18, which I'll talk about in some time. But the urine output will start falling dramatically, and the patient will go for oliguria or probably anuria. That's why this phase also called as oliguric or oligoanuric phase. There might be a complete loss of urine output, and the serum creatinine will peak here, will increase, and it will usually peak. Maybe it might become 5, 6, also 10, also depending on the severity of the injury. And patients might start getting uremic symptoms. Uremic symptoms might start appearing, and the patient will usually most of the times go for dyselectrolytemia. The most important is the hyperkalemia. There are a lot of electrolytes can be abnormal, but hyperkalemia is very, very important. And the patient will go for volume overload state. That's because of severe decline in the GFR. Because of severe decline in the GFR, the water, sodium, all the things cannot be filtered. So there will be severe volume overload in this guys, and the patient will start getting acidosis as well. And that is because of the accumulation of the uremic toxins. At the same time, organic acids cannot be filtered because of loss of GFR, and the patient will start getting acidosis. So here, once again, the treatment remains the same. You might need to stop the offending cause at this point. Otherwise, the kidneys will become more bad. Plus, you need to give some supportive treatment. Like supportive treatment in the sense you can try correcting this hyperkalemia. You can try correcting this volume overload state by giving aggressive diuresis sometimes. I mean, not all the cases. Suppose if the patient is due to burn increase in perineal because of increased absorption and ATN because of decreased filtration. Yes, of course, correct. So that's right. So this is a very trivial thing, but there are so much into it. So that's why we don't want to talk the entire kidney physiology, which becomes even more complicating. So if you want to really know, you need to know something called urea recycling mechanisms and how urea is recycled and how in ATN urea recycling is affected, how in prerenal failure urea recycling is affected. And apart from that, you have certain cation exchanges, how they work, and that's too much. So what you told, Keshav, is maybe to an extent is right. In prerenal because of increased reabsorption, and maybe in ATN because of reduced filtration. That must solve the debate for now, at least. So then you have a supportive treatment like diuretics, or probably you can give that hyperkalemic therapies. Plus or minus, you might be needing hemodialysis if there are indications. If indicated, you might be even needing a hemodialysis in this particular patient. So this is what you're going to do. Clear? So maintenance phase. Finally, during the maintenance phase and during the initiation phase, you will be starting to get one important finding in the urine. So let us see what are the findings you might be getting. The one finding that you'll be getting is the sodium and urea in the urine. So first thing is the sodium cannot be reabsorbed because of the poor tubular function. And second thing is the urea cannot be reabsorbed as well because of the poor urea reabsorption. And the third thing is the water also cannot be reabsorbed because of the poor water reabsorption. Even though ADH might be there, but it will not work because of the poor tubular function. And the tubular secretion of creatinine is also affected very dramatically because of the poor tubular function. But all these things will tell you one important thing, that the urinary sodium will be very high. So, but remember, I'm talking about whatever urine that is remaining. So in that only we are talking about. We are not talking about the poor filtration that has already caused substantial increase in sodium and water in the body. But whatever urine that is coming out, whatever minimal urine that is coming out, whatever urine that is going through this damaged tubules, that will have, that small urine also will be having high urinary sodium, and they'll be having a high fractional excretion of sodium. And of course, they will be having a high fractional excretion of urea. And of course, they will be having a low urine osmolality because they cannot absorb water. And they'll be having a low specific gravity. And in fact, most of the time, they'll be having a fixed specific gravity of 1.010, which means that indicates a concentration failure. So usually this low urine osmolality and fixed specific gravity is the usual initial thing, first thing most of the times to happen in the patient with the acute tubular necrosis. So this is what is going to happen. So, and at the same time, patient of course will be oliguric. There is no doubt about that. Most of the patients will be oliguric. And if you take the sediments, this is very classic. The sediments will be active. You'll get an active sediment, and we know what sediment you're going to get. This is the muddy brown cast. So this is nothing but this this particular, this tubular cells that are necrosed will come out in the urine as a cast. So like that itself, they'll come out in the urine, and that's what we call it as a muddy brown cast, or probably a granular cast or granular cell cast. So that is very characteristic of acute tubular necrosis. The sediment will be active here. So that's very important as well. At the same time, patients might get uremic symptoms, and patients might get a lot of other problems. So many uremic symptoms are there, which is beyond the scope of the current discussion, but they can get anything during this phase. Finally, they will go for something called a polyuric phase. During the polyuric phase, and we're going to talk about the Bunn creatinine ratio. Here, the Bunn creatinine ratio will be something different. So if you want to talk about the Bunn creatinine ratio, here the urea levels will be very high as well. That is because of extremely poor filtration of urea. Even though urea in the urine appears to be a little high, but it's only fractional excretion. We are talking about whatever urine is there, whether that urine is having high urea or low urea. We are talking about that. So here the blood urea will be extremely high because of the poor GFR. Bunt ratio will be very high, and at the same time the creatinine also will increase to a great value because there are two reasons. One, for poor GFR. At the same time, the tubular secretion of creatinine is also taking a huge hit. So because the creatinine also will rise tremendously. So there will be usually a comparative rise between both. So usually the ratio will be okay, will not be elevated. Either it will be less or maybe normal. So it will not rise. That's the take home point. Clear? So it will be less only, usually. It will be maintained because of increase in both blood urine nitrogen and creatinine. But in polyuric phase, this is the final phase. This is also called as resolving phase of ATM. Here the urine output will basically increase, which means what I'm trying to tell is other abnormalities will resolve. But once the tubules start recovering and all the sloughs are removed and the injury is also not there anymore, and now the kidney start trying to reverse itself depending on severity of injury, they might reverse more or reverse less. The urine output will start increasing, so they'll go for polyuria. And the serum creatinine starts decreasing, in the sense I'm not telling it will decrease to less than 0.2 or 0.2. It will start decreasing means it might become normal or may not be normal. For example, start with 0.8 during the initiation, maintenance phase, it become 4. After that, either it might become 0.8, come back to normal, or it might go to somewhere around 1.9 and I can maintain there. From there on, it will be 1.9. That will be, what I'm trying to tell is there might be a permanent loss in the GFR of the patient, or the patient might come back to the normal routine renal function, normal GFR also. Again, depends on the severity of the injury and the type of the injury. Some patients may lose a part of GFR permanently, which means the permanent loss of the GFR will be there in certain patients, or some patients may come back to the normal GFR, how they were been before. So it depends, but the serum creatinine nevertheless starts decreasing in this situation. It comes back to a little lower value, and uremic symptoms will disappear. No uremic symptoms usually, and patient will still get dysalkalotemia, but usually in this setting they'll go for hypovolemia, that is hyponatremia, hypokalemia, and the patient will start going for hypos rather than hypers in this, and the patient will go for dehydration rather than volume. Dehydration rather than volume overload state, and there will be usually no acidosis in this particular situation. So treatment here, already the offending cause has been reversed, so not a problem. So here all you need is supportive treatment. For example, you can give fluids, electrolyte replacement. So that's what you're going to give, and you don't need anything else. You just wait for the creatinine to come back to normal and the patient's urine output to become normal. Remember, the first to get lost is also the urinary concentration. The last to recover is also the urinary concentration. Because why you get polyuria? Because the obstruction will be gone, the sloughs will be over, but still the tubules that are damaged are now only regenerating, and they are not yet fully got their functions. That's why still there will be poor urinary concentration and they cannot absorb any solute or solvent, and so they will be excreting a lot of solutes and solvent, because you can understand that whatever that was obstructed initially here at this point might start going down during this phase. So there will be a polyuric phase. That's what happens here. So this is the basic difference between a pre-renal AKE and a acute tubular necrosis. If you want to put this into our number perspective, suppose if you have a pre-renal AKE and if you have acute tubular necrosis, you know what's going to happen to the urine osmolality. Urine osmolality is going to be high here, urine osmolality is going to be low here, and just give a number to it. More than 500 usually, it will be less than 350. And we know specific gravity is going to be higher here because of high urine osmolality, more than 1.020 usually. It will be less, it will be less than or equal to 1.010. They cannot concentrate the urine. And at the same time, oliguria is something that will be seen in both. It's not like it will not be seen only in this or that. It can be seen in both. I can write plus or minus. That will be correct. It's not a very important thing. There are a lot of conditions produce non-oliguric type of AKE also. So it can be having oliguria or not having oliguria, doesn't matter. So oliguria may or may not be there. But sediments, typically bland, no sediments. Here the sediments will be active. You'll be seeing the classic muddy brown cast or granular cell cast. And as far as urinary sodium is concerned, we know here it will be less because of high RAS activity. Here it will be more because of poor tubular function. So typically you give a number to that. Here the urinary sodium will be less than 20 most of the times. Here it will be more than 40 usually. Then fractionalization of sodium, that's called FeNA. So FeNA is also referred to as something called the renal failure index, RFI, which is considered to be the gold standard to differentiate between pre-renal and intrinsic renal AKI. But nevertheless, FeNA is sometimes unreliable, especially in the setting of contrast or rhabdomyolysis. It is actually unreliable. I'll tell you why later on. So in pre-renal, just hold on. FeNA. So FeNA is also called as a renal failure index, where in pre-renal FeNA will be low, typically less than 1%, whereas in acute tubular necrosis FeNA will be high, it will be more than 1%. Then we have the next thing, that is the fractionalization of urea. We know here it will be low, it will be high. We've already seen that. So just give a number to that. Typically it will be less than 35% here, and typically it will be more than 55% here. As far as, FeNA I can write more than 2%, that's better. So it will be less than 35, here it will be more than 35%. And we also do have other parameters. I already told you about the sediment, so fine. So these are the classic differences between pre-renal AKI versus acute tubular necrosis. So this is very important to note, but please do remember there are some pitfalls here also. So even though FeNA is considered to be very standard and classic for differentiating between a pre-renal failure and acute tubular necrosis, there are quite a few things that you need to know. There are some conditions which produce acute tubular necrosis, but still they can have a pre-renal picture. So best examples of those conditions. So one example is if you have a free hemoglobin or myoglobin. Let us assume a condition called rhabdomyolysis, and second condition which cause contrast-induced nephropathy. Most of the time this is actually acute tubular necrosis. It could be acute tubular necrosis. Patient might have acute tubular necrosis, but still FeNA can be less than 1. So this, I'm not telling all the situations. Whenever I tell this kind of exceptions, it doesn't mean that all the times rhabdomyolysis and contrast nephropathy will have FeNA less than 1 only. They might have FeNA more than 1. I'm not telling, but usually we'll encounter a FeNA of less than 1, despite the fact that they produce an acute tubular necrosis. Why? Because these actually induce myoglobin, and the contrast induce severe vasoconstriction. Because they induce serious vasoconstriction, they can actually result in hyperactivation of renin-angiotensin aldosterone system, and that can actually result in FeNA of less than 1. That's the reason. So because of too much of vasoconstriction, NSAIDs can do that, but NSAIDs usually come with a different picture. Always a pre-renal picture. NSAIDs usually does not result in acute tubular necrosis, as far as I know, unless and until you have a very, very high dose of NSAIDs. But that much dose of NSAIDs we don't use in reality. But to be honest, NSAIDs I would not have written in acute tubular necrosis, did I? I don't think so, I guess. Yeah, usually NSAIDs don't cause. Even subconsciously, I don't write NSAIDs in acute tubular necrosis. NSAIDs I have already written only in pre-renal failure only. So usually they cause pre-renal only. But analgesic nephropathy is something that presents in a much different way, which we'll be discussing if there is time. So I was telling about, yes, rhabdomyolysis and contrast-induced nephropathy. And there is another condition. The two conditions are there. One is called sepsis, and second is hepatorenal syndrome. Sepsis and HRS, sepsis and hepatorenal syndrome. These are two conditions which are almost always pre-renal. Almost always pre-renal. If you see the sepsis and hepatorenal syndrome, I'd have told that it can cause pre-renal as well as intrinsic renal. So where is that? You can see that cirrhosis, that is hepatorenal syndrome, and probably I'm talking about a sepsis here, which can cause pre-renal. At the same time, there could be associated, where is that, intrinsic renal failure as well. So these are conditions that can produce pre-renal or intrinsic renal or an acute tubular necrosis, but the blood, I mean, the urinary picture will always be like pre-renal only. There won't be intrinsic renal picture at all, which means almost always FeNA in this situation, even if there is an associated acute tubular necrosis, when you have a sepsis or a HRS, FeNA will always be less than 1, almost always. The reason is because there is again a serious vasoconstriction that is happening in these situations where your RAS system will be too much active, and that will cause too much sodium reabsorption, and FeNA will almost be always less than 1. So these are some exceptions that you need to know. Sepsis, HRS, even if there is a underlying acute tubular necrosis, almost always FeNA less than 1. And in patients with rhabdomyolysis or contrast nephropathy, even in the presence of an acute tubular necrosis, which can be caused by this myoglobin and contrast itself, but still the FeNA will be less than 1, once again due to RAS activation. These are 4 conditions that you need to know. Almost always FeNA will be less than 1, despite the fact that there can be an underlying acute tubular necrosis in this patient. So some examples. So that's why FeNA is not a gold standard, or FeNA is not extremely typical of suggesting of a pre-renal versus intrinsic renal. But I will believe that as a beginner, you need to know this. But when you move on to your additional practice in medicine or probably in nephrology, you don't take the stuff that important. You always try to diagnose clinically. So the more the creatinine is there, I will think about more the possibility of acute tubular necrosis, because in pre-renal I always have only a mild increase in creatinine. But if I see a urea of 165 and I see a creatinine of maybe 6.1, so urea of 160, creatinine of 6.1, or maybe I can tell urea of maybe 250, urea of 250, creatinine of 6.1. I can't call it as a pre-renal, because even though urea is 250, maybe blood urea nitrogen can be approximately maybe 125 here approximately, and creatinine is 6.1. Definitely the Bunn creatinine ratio is more than 20. There's no doubt about that. Even if the Bunn creatinine ratio is very high, I cannot really think about pre-renal as a primary problem here, because pre-renal by default should not produce this much of creatinine. If it's a true pre-renal, there should be an underlying intrinsic renal injury, and there should be an underlying acute tubular necrosis. So it all depends, again, boils down to your expertise and your background clinical information on the creatinine. So 6.1 creatinine diagnosing as a pure pre-renal and starting the treatment, even if with the Bunn creatinine ratio is very high, doesn't make any sense at all. That's really, really bad. And I didn't write the Bunn creatinine ratio. We know that the Bunn creatinine ratio will be increased here. It will be typically more than 20, or the Bunn creatinine ratio will be decreased. Typically, it will be less than 15. It will be typically less than 10 to 15. But all these things are only for understanding. But in reality, there are a lot of modifications that you need to know when you want to understand all this stuff. Okay, fine. We knew that. So these are the difference between pre-renal and acute tubular necrosis, which you need to know. So I think we have substantially described this pre-renal failure versus acute tubular necrosis. So we have some other causes, like how will you find out vascular cause? How will you find out? I mean, glomerular I'm not going to talk about anymore, because glomerular we have had a detailed discussion. The only 2 things that is still left in your acute kidney injury is the acute interstitial nephritis and the vascular causes. So let us start with acute interstitial nephritis. In exams, it's quite simple to diagnose an acute interstitial nephritis. There will be some classical pattern to diagnose an exam. So acute interstitial nephritis is of many types, but the number 1 cause in exam is always drugs. Even in reality, it's the drugs always, but the number 1 cause in exams is always the drugs. Drugs. That's all. And the number 2 cause is always connective tissue disorders, CTDs. Connective tissue disorder, this is what is number 2 in exam. And the number 3 in exam that you need to think about is the infections. Very rare, but they won't give an exam. But maybe third possibility you can think about infections. These are third thing that can cause acute interstitial nephritis. And finally, number 4, very rarely you might get some infiltrative causes. Rarely, very rare. Usually don't diagnose this in exam. The order of diagnosing the cause of acute interstitial nephritis is drugs to connective tissue disorder to infections to infiltrates. This is the order. In the drugs, if somebody asks you the number one cause of drugs in India, it's always NSAIDs. NSAIDs, NSAIDs, NSAIDs. And drugs typically produce a type of pattern called as allergic interstitial nephritis. So they produce an allergic AN. That's what they do. They produce an allergic acute interstitial nephritis. That may also be a question exam. The number one cause as far as India is concerned is NSAIDs. But if you take the Western world, if you go to the maybe UK or US probably, the number one cause they would have given is proton pump inhibitors. And PPIs have been said to cause a lot of AN, but in India it's not that common. So, but in Western world, this is really, really important. So proton pump inhibitors, PPIs. So these are the two drugs that you need to know for exams. But I believe in India usually NSAIDs. So in exam also you will get a lot of causes pertaining to NSAIDs only. And apart from that, you can get with some beta-lactam drugs, like even with cloxacillin or probably some augmentin. So some sulfa drugs can cause, even cotrimoxazole can do that. So many drugs are there, but these are the 4 drugs that I need you to know. And you can get with certain connective tissue disorders. As far as connective tissue disorders are concerned, I'm going to talk about Sjogren syndrome, which is extremely important. So many times in Sjogren syndrome, if you get a AKI, you think about AN. If you get a acidosis, you think about a distal RTA. So these are very prototypical questions in exam. Sjogren patient with nephrocalcinosis and acidosis, it's equal to distal RTA, because very, very important for exam. And second, Sjogren syndrome patient with kidney injury is always an allergic interstitial nephritis. 2 things are very, very common. And SLE, of course. SLE can cause so much of problem, but typically it will be lupus nephritis. But remember, lupus nephritis will have a different picture. I told you already. Type 1, how it will come. Type 2, how it will come. Class 3, class 4. Class 3, class 4 will have hematuria, RBC cast. Class 5, membranous, heavy proteinuria. Class 6 is CKD type. But SLE patient can get acute interstitial nephritis also, but that pattern will be different. You won't have that hematuria. You won't have this RBC cast. You'll be coming with a completely different pattern. So SLE can cause AK due to allergic interstitial nephritis. And you can get with something called as IgG4 related disease that's coming up. I think I've described about IgG4 related disease in the triad of histological findings in rheumatology itself, where you see that obliterative phlebitis and storiform fibrosis and venulitis. So I think I've told you all these things already. And IgG4 secreting lymphoplasmacyte or infiltrate. We have discussed it already. And at the same time, IgG4 related disease typically presents with mass-like lesions in many areas. They will typically resemble tumors. Because they resemble tumors, you always have to take a biopsy whenever you think about an IgG4 related disease, where you see classically the triad of findings. You see that it's IgG4 related disease. Serum IgG4 50% may be elevated, but half of the patients may have normal IgG4, so it's not reliable. Biopsy is the gold standard. So IgG4 related disease can produce a sort of interstitial nephritis, AN-like picture. And there is another one called a Tinea syndrome. TN, that's called a tubulointerstitial nephritis with uveitis. This can be caused by variety of connective tissue disorders. It can be idiopathic. If you have an idiopathic tubulointerstitial nephritis, you don't have any cause underneath. Plus, you have a uveitis along with AK in exam. Uveitis with AK in exam, you can diagnose a Tinea syndrome. But even it can be caused by sarcoidosis. For example, infiltrated, the first thing I'm going to tell is sarcoidosis. Sarcoidosis can also produce an interstitial nephritis along with uveitis. You know, they're going to produce that granulomatous uveitis, which can present like a Tinea syndrome. But please understand, if there is a cause like sarcoidosis, you don't call it as a Tinea syndrome. If there is no cause, then only you're going to call it as a Tinea syndrome. And let us finish out the infiltrative cause. As the infiltrative cause is concerned, you can get with lymphoma or leukemias also, which can infiltrate rare conditions. But in this, I would like to remember only sarcoid. Here, I'd like to remember only Sjogren syndrome, nothing else. Here, I like to remember only NSAIDs and PPIs. That's all. So these are important for exams. And as far as infections are concerned, many infections can cause, but the number one infection exam that you need to know is Legionella. Legionella pneumophila. You know the triad of Legionella. They produce atypical pneumonia. They produce GI prodrome, that is diarrhea. They can produce allergic interstitial nephritis plus or minus hyponatremia or acidity. Classic triad, but complete Legionella. Drug of choice, of course, for Legionella is levofloxacin. We know that Legionella can cause this picture. At the same time, there are multiple other conditions that can produce viral illness, many viral illness can produce AK, like parvovirus B19, is very important. At the same time, tuberculosis can cause genitourinary TB. Very easy to diagnose, but I'll tell you how to diagnose genitourinary TB. At the same time, you might get with leptospirosis. This is very important as far as Indian practice is concerned. So if you want to remember two infections, one is Legionella, second is leptospirosis. These are two infections I need to remember. Two L's maybe I can think about. So two infections, Leptospira, Legionella. Very, very important. Both of them cause acute interstitial nephritis, AN. So what will be the constitutively, what will be the features of interstitial nephritis? Number one, majority of the cases, majority of them will be non-oliguric because it affects only the tubulointerstitial area. So they don't really affect the GFR that much, glomerular filtration. So most of them will be non-oliguric kind of AK. AN will be typically non-oliguric because they don't affect the GFR. They just affect the tubules in the interstitium. Or they will affect only the interstitium. So they will be non-oliguric. And second thing is the urine that you see. The urine typically you will see either can be bland, or you can see a WBC cast. WBC cast, or you might see an epithelial cell cast. So anything can be seen. But very commonly, you will see WBC casts. Very commonly. So this is what you will get in exam, WBC cast. So allergic interstitial nephritis or an acute interstitial nephritis, but you don't really see RBCs. Usually no RBCs and no RBC casts. So if that is the case, then that goes towards probably maybe a glomerular nephritis. But no RBC cast is the most important. But even though some UTIs, urinary tract infections, can cause AN and can produce some RBCs, but they won't be dysmorphic. I'm talking about this is something that is told to tell that it's not a glomerular cause. That's what I want to tell you. So clear? This is number two. And you might see WBCs, actual WBCs in the urine, even without a cast. And most often what they'll be giving is this WBCs in the urine will be eosinophils. That's what we called as eosinophiluria. Eosinophiluria or eosinophils may be there. And typically this eosinophiluria is seen in allergic interstitial nephritis. And mostly in the setting of probably some infections I told you that can cause this thing, you can get eosinophiluria. But even though this is supposed to be very common in exams, but in reality it's not extremely common. It can be very rare. You can see a different form of picture. For example, if it's a antibiotic cause, infection related, or if it's antibiotics causing allergic acute interstitial nephritis, then you might get eosinophils in the urine. Otherwise, if you have NSAIDs, usually you will not have eosinophils. Most often you will see lymphocytes in the urine. Lymphocytes in the urine. Rather than seeing eosinophils in the urine, you might be actually seeing lymphocytes in the urine. So whenever you see eosinophils in the urine, it's more of an infection or probably antibiotics like penicillins, beta-lactam, sulfa, trexcotrimoxazole causing acute interstitial nephritis. So seeing a WBC cast, seeing WBC in the urine, seeing eosinophiluria, eosinophils in the urine. So this completes that this patient is having an acute interstitial nephritis only. Or seeing more lymphocytes in the urine also tells you that this patient is probably having a acute interstitial nephritis. And number three, there can be optional eosinophilia, even though that is not very classic, not seen in majority of the patients. Or you might see a rash, especially in infection. Infectious causes, you might see an associated rash as well due to allergy. And what other things? And you might see proteinuria. So typically it will not be in the nephrotic range, it will be in the subnephrotic range only, maybe usually in the range of probably somewhere around 1 to 2 grams per day. Tubular proteinuria, but not much. I mean, again I can write plus or minus proteinuria. So these urinary findings are very, very important. So in exam, it's very easy to find out a case of AN. You'll be having some drug use history, definitely. Followed by that, there will be patient will usually come with weakness and fatigue. And if you see the serum creatinine, it will be elevated. And if you see the urine, most of the times they'll be telling urine eosinophils are increased. Or they might tell urine is showing a WBC cast, but they are clearly given, but there is no RBC cast. WBC cast, but there is no RBC cast. And they'll also give an ultrasound is looking okay, completely normal imaging wise. So kidneys are okay, kidneys are not showing any problem. So that's it. So this patient is having a AN only by default. So this is how you diagnose an AN. So see eosinophils in the urine, high creatinine, history of drug use. It is acute interstitial nephritis. Here it is of allergic type because there is a drug history. It's a very, very common question in exam. So most of the time they will be non-oliguric. They won't be oliguric in the first place, so which is very important to know. As far as treatment of AN is concerned, usually supportive, stop the offending agent, stop or treatment of underlying cause. That's very, very important. And the second, steroids. So what is the role of steroids? Steroids can be given, since drugs are very common. Steroids can be given if the disease is early. For example, early steroids are beneficial. If you're giving early, then beneficial. Early means you should have a time cutoff, maybe within 48 to 72 hours, maybe. But I usually give a cutoff of 48 hours. Beyond that, usually it will not be effective. So within 48 to 72 hours, if you're giving steroids, then probably it might be beneficial. That's all. And whether you need to know biopsy or not, yes, sometimes we need to do a biopsy, because if the urine is bland, suppose all these things theoretically you have in exams, but in reality you might not have. The patient might just come with a non-oliguric AK, just with a weakness, high creatinine, and the patient is not having anything, just a bland urine, and no other clues to tell that it's an interstitial nephritis. So in that setting, I need to do a biopsy for sure. The patient has a strong history of drug use recently. Temporal assessment is good. For example, 1 week back, I started a NSAID for the patient. So in the COVID era, I've seen a lot of patients coming with this kind of allergic interstitial nephritis. I've seen 4 cases till now. One of them is a doctor. So he's a surgeon who had rise in serum creatinine. His creatinine went to 2.4. He's a healthy man otherwise. He got a COVID and used indomethacin. And after that, he came with weakness, tiredness. We just checked for RP1. I mean, we just checked for the creatinine. It was 2.4. And he got scared. But we are very clear because there was a strong history of indomethacin use just 5-6 days back. So we are very sure that it is acute interstitial nephritis. And we just waited. We didn't do a biopsy. We are thinking about doing a biopsy maybe if the creatinine starts rising. But we are waiting, just supportive care and like the patient become normal within 5-6 days. Creatinine become 1.2, 1.3. We discharged him, and before 1 week back, when we checked the creatinine again, it was only 0.7, 0.6. Came back to normal, luckily, completely. So biopsy may be needed in some cases where creatinine is worsening, or maybe we don't have a clue. Creatinine is not improving at all. So if it's an allergic interstitial nephritis, you will be seeing inflammatory infiltrates in the interstitium. It could be lymphocyte or it could be eosinophils. Doesn't matter. It could be a mixture of infiltration, but typically you will see an acute inflammatory infiltrate in interstitial area. Interstitium, typically. So this is a classic biopsy finding, and that's straightforward. And remember, steroids, if given early, may be beneficial, but very late steroids may not be beneficial. But certain conditions will mandate use of steroids. Like suppose if it's a connective tissue disorder, Sjogren, SLE, IgG4. So in this condition, I need to, or a Tinu syndrome, I need to use a steroid for sure, because steroids are the treatment of that particular disorder itself in the first place. So I need to use steroids. Sarcoid maybe. So steroids are the treatment for that disorder. So in that condition, you need to use a steroid. But apart from these conditions, other conditions, if you want to use a steroid, it should be early. Otherwise, it won't be beneficial. So this is acute interstitial nephritis. Very, very important for exam. So causes and the probable treatment. Then we are going to vascular causes. Do you understand whatever I told till now? Okay. Keshav is asking, this patients will have problem in urinary concentration because interstitium is affected. Of course, yes, they will have problem in urinary concentration. That is why I told you they are non-oliguric. They don't have oliguria. In fact, they might have polyuria also, certain patients. But it again depends. It boils down to the extent what is the amount of kidney damage and what are the areas that are affected. So typically, interstitium is affected means again they cannot concentrate the urine. So that's quite common. Then coming to the vascular causes. Vascular cause, the first thing I need to show you is an image maybe. I can try showing an image, it might be beneficial. Maybe I think I have not got that image. Yeah, got it. So if we show you this image, so what is your diagnosis? Straightforward. I'm showing an image like this. So what do you think is the diagnosis? I mean, you don't see anything else. Just seeing this image, you can make a diagnosis. I mean, kind of a spotter. What is the diagnosis here? Onion skinning, okay. What else? This is not what you think, basically, because many of you are thinking it's onion skin appearance, maybe malignant nephrosclerosis. That's what, no, it's not like that. So this is something called as a cholesterol emboli. Cholesterol emboli. This is actually a glomerulus. If you see, this is not a vessel. If it's a vessel, I can understand. So why it's not a vessel in the first place? Because you can see the tubule here. This is a maybe renal tubule. And having a vessel as big as the tubule is first of all ridiculous. You don't get this much big vessel. The glomerular vessels will be small, and getting a vessel as big as the tubules is, I mean, I don't think it's valid. First of all, what you're seeing here is actually the glomerulus that you're seeing here, and inside the glomerulus, we have some vessels, and the vessels are a little big. And in these vessels, these are probably the vessels that we are seeing inside the glomerulus. In these glomerular vessels, you can see some kind of needle-shaped crystals. These are basically rod-shaped. You can tell asymmetric rod-shaped or needle-shaped. These kind of structures you see inside, these are actually the cholesterol emboli. So if you get something like this, these are actually obstructing the glomerular vessels, which means they are producing a kidney injury due to vessel involvement. So maybe a large vessel actually getting involved, so causing a cholesterol, obstructing the blood flow to the kidneys, causing a cholesterol emboli. So that's what is actually happening here. So it's actually a vascular cause. So it obstructs the blood flow to the different portions of the nephron. Maybe a huge large vessel may be obstructed with these crystals, resulting in low perfusion to the kidneys. So basically cholesterol emboli happens after an invasive angiographic procedure. Invasive angiographic procedure. In exam, the best example of an invasive angiographic procedure is going to be the coronary angiogram. It's basically going to the coronary angiogram. That's going to be the best example of an invasive angiographic procedure in the first place. So in this setting, there is one more important differential diagnosis. So usually in exam, they'll give a coronary angiography as a history. There will be history of coronary angiography, and followed by that, the patient might develop an acute kidney injury. If they develop acute kidney injury after a coronary angiogram, there are multiple differential diagnoses. But usually, what are the two differential diagnoses that we need to think about is one is contrast-induced nephropathy, because here the reason for AK is the contrast, and second thing is the cholesterol emboli. Cholesterol emboli, or I can call it as an atheroembolic disease. Cholesterol emboli. Here the reason, maybe I can write atheroembolic disease. That's the right terminology. Here the reason for development of this atheroembolic disease is the cholesterol emboli. So this catheter that is going into the vessel might disrupt some atherosclerotic plaques, and they might shred down the atherosclerotic plaques, resulting in dislodgement of these plaques, and like they can go to different areas in the body, and they can produce this infarcts, and they can go for organ failure. So in kidney is one area that can be affected. So atheroembolic disease. So how will you differentiate contrast-induced nephropathy versus your atherembolic disease. There are many ways to differentiate a contrast nephropathy versus atherembolic disease, but typically in contrast nephropathy, the timing of the AK is very, very important. Usually it will be in day 1, day 2. AK that happens around day 1, day 2 is very typically a contrast nephropathy after a coronary angiogram, after contrast, which means it happens within 24 to 48 hours post contrast. Whereas in patients with atherembolic disease, you might get acute kidney injury by around day 4 to day 7, even though the day 5 is classic. Day 5 is most common. So in exams, day 5 is very common. I don't know why they like that day 5 very commonly. So, but day 5 disease is extremely common as far as atherembolic disease is concerned. So usually contrast nephropathy, the risks are there. The most important risk is hypovolemic state. Hypovolemic state or low hydration of the patient, the risk of getting more contrast nephropathy, or if you're using a more contrast volume, so too much contrast volume, number 2. And at the same time, you might be having an associated nephrotoxic drug. Patient might be using some nephrotoxic drug, nephrotoxic agent. At the same time, not only increase contrast volume if you're using an ionic contrast. Typically, we use a non-ionic contrast, but if you're using more of an ionic contrast or if you're using more and more contrast volume, the risk is actually higher. As far as cholesterol emboli is concerned, it can happen after any situation, but usually femoral route actually has a higher risk because when you're going through the femoral route, to enter the aorta, you need to go through the like that. I mean, to go to the coronary arteries, you need to cross the abdominal aorta. So abdominal aorta, is the storehouse of atherosclerotic plaques, and it's going to have too much of atherosclerotic plaques in abdominal aorta. So femoral route actually has a higher risk, or patients who are extremely old age, then probably patients who are having multiple ASCVD. Already patient is a known case of stroke, patient is a known case of renal artery stenosis. So multiple other atherosclerotic cardiovascular disease is there. So these are the patients who are at high risk of developing atherembolic disease. But nevertheless, as far as the symptoms are concerned, usually they will be completely asymptomatic contrast nephropathy. In the sense, they will be completely non-oliguric. They won't have any oliguria at all in the first place. They'll be totally asymptomatic. And as far as the investigations is concerned, the only problem that you'll be expecting is a high serum creatinine. You don't really see anything else apart from the high serum creatinine. Usually there won't be much uremic symptoms. So totally they'll be asymptomatic. And electrolyte disturbance also will not be there. At the same time, this patient will be having typically a pre-renal picture most of the time. Even though it's a acute tubular necrosis, they might be having a FeNO of less than 1 usually. But in exam, it is variable. But in reality, you'll have a FeNO of less than 1 because this contrast induces a powerful vasoconstriction, and that will activate RAS, and usually they will be having a FeNO of less than 1 only usually. And at the same time, treatment wise, there's no much treatment. It's a benign condition. But there are some people who can be affected with this contrast nephropathy, especially with those who are with pre-existing renal failure. Those who are having a pre-existing renal failure, like CKD patient who are already having a high serum creatinine. So these patients can go for a permanent loss of eGFR. Permanent loss of GFR, no problem. These patients can have a permanent loss of GFR, which means what I'm trying to tell is like what we have seen in acute tubular necrosis. Initially, if serum creatinine is 0.8, after a contrast, it might become maybe 1.6. You expect them to come back to 1.8. That usually happens in the setting of a usual patient. But if the patient is already having a creatinine of 1.9, after giving a contrast, it becomes 2.4. And many patients will come back to 1.9, not a problem. But there are some patients who can go to maybe 2.1, and they can maintain there itself. Which means what happened is after contrast, the baseline creatinine is actually shifted to 2.1, and there is some permanent loss of GFR that is happening. So that's the risk with a patient who's already in a pre-existing kidney injury. Suppose if I am the case, or if anyone else is the case, so if I'm having a normal creatinine, no problem at all. But in a patient who's having a pre-existing renal failure, there could be a permanent loss of GFR. This is the risk that is there with the contrast. So that's why in patients who are having a high creatinine already, we fear giving a contrast, but in all the other cases, we can give contrast in and out, not a problem at all. So as far as this atheroembolic disease is concerned, most of the patients will be symptomatic, in the sense like so many symptoms will be there, like they might be having a low grade fever, they might be having arthralgia, and they might be having other problems of cholesterol emboli like ischemia to other organs, ischemic symptoms. So other ischemic symptoms include a patient might be having this blue cyanotic dose, that is due to digital influx caused by this cholesterol emboli to smaller capillaries which are getting occluded. Apart from that, you can get this Holland-Hurst plaques, amaurosis fugax. Holland-Hurst plaques are this cholesterol plaques that obstruct the arterioles in the retina. You can produce Holland-Hurst plaques. So these are some of the other ischemic symptoms that you can get. And oliguria depends. Urine output is variable. They can be non-oliguric or they can be oliguric depending on what is the status. But in exam, typically they'll be oliguric, but in reality they'll be variable. I mean, depending on severity, they may be oliguric or they may be non-oliguric also. As far as the investigation is concerned, definitely there will be high serum creatinine, no doubt about that. Typically, it will be a intrinsic renal picture. FeNA is once again variable. You cannot tell for sure FeNA will be more than 1 or less than 1. Usually, even though it's more than 1, but you cannot really comment on that. But more important point is the fact that these patients might be having low complement levels, because this cholesterol emboli consumes the complement. So C3, C4 levels may be low, complement levels may be low. As far as treatment is concerned, it's mostly supportive. You need to treat the, like electrolyte problems and volume overload. If that happens, plus or minus, they might be needing a hemodialysis. Suppose whether you need a biopsy or not, typically you don't need, I don't really do a biopsy. If I do a biopsy, if done, I mean, I don't need, if there's a clear-cut temporal association with the contrast, then followed by, you get a characteristic timing of AK, I don't really do a biopsy. Even if the creatinine does not falling, I'll wait for some time. Suppose if creatinine is, if biopsy is done, you will see vacuolation of tubular cells, especially in the proximal convoluted tubule. So this is a characteristic finding. So the key point here is the vacuolation. But in exam, you might ask, but in reality, I don't even need the biopsy. I don't do biopsy. Here, if biopsy is done, and most of the times it will be done here, because the timing of the AK is a little late, day 4 to day 7, classically around day 5. But it could be some other cause also. I don't know. It might be due to like the patient might be getting some other forms of AK, but I don't know. So biopsy might be done. If I do a biopsy, you know what I'm going to see. I'm going to see in this cholesterol emboli obstructing the medium-sized vessels. Medium-sized vessels resulting in ischemia to the glomerulus, ischemia to the kidney. This is what is going to happen. But the small vessels will be okay. Small vessels will be okay. That's why I told you. A structure that you see as big as the tubules must be either a medium-sized vessel or probably a glomerulus. So apart from that, you cannot see that big structure. So and there can be reactive hyalinosis around that particular vessel, as we saw in the previous image. So this is what you see typically, that crystals, that crystal-like appearance. Usually they'll be like rod-shaped or needle-shaped. That's how they look like. So this is a characteristic cholesterol embolic disease, atheroembolic disease. But in exam, it's very easy to find out. So usually they will give a history of coronary angiogram. After that, the patient will come with an acute kidney injury, see the timing, first day, second day, or fifth day, sixth day. So if early, go for contrast nephropathy. If it's late, go for atheroembolic disease or cholesterol emboli. So this is what you're going to see. This is the first vascular cause we need to know. And prevention. Contrast nephropathy can be prevented to a large extent. Suppose why we need to prevent contrast nephropathy? Because we know there are some patients who are at risk, especially those who are having pre-existing renal failure. These patients are at higher risk of developing contrast nephropathy and subsequently permanent loss of GFR. So Harishitam is asking, is there any role of anticoagulation? Anticoagulation may be tried, but cholesterol emboli does not really work that much with antibiotics. You don't really you can't really treat much with anticoagulants. there's very poor role of anticoagulants. You can give if you want, but that's having only a marginal evidence. But many of the trials have shown typically no evidence for anticoagulants. You just have to treat supportively. And this is an unexpected disorder as well. And most of the patients will already be on anticoagulants. So no need to worry about that because already you would have given a coronary angiogram. So what is the role in anticoagulants? Majority of the patients after coronary angiogram means they will be on antiplatelets or anticoagulants. So giving an additional anticoagulation, I don't think it will be much effective. And how will you prevent? So prevention is very important. There's so many trials, so many data as far as prevention of contransfused AK is concerned. But the number one is always hydration. Proper hydration is going to be the most important. Hydration by simple normal saline is basically more than enough. You don't need to do much here. So just a simple normal saline hydration is actually typically more than enough. Like I'm going to use only isotonic fluids. But there has been some studies which show I can use hypertonic solutions also, like soda bicarbonate solutions. And typically, like the soda bicarbonate solutions has been tried in many outpatients as well as inpatients. So what they are trying is like pre-procedure and post-procedure. So before the procedure, just 1 hour before, you're going to give a soda bicarbonate infusion of 3 milligram per kilogram per hour for 1 hour. And post-procedure, you continue with the soda bicarbonate infusion of approximately 1 ml per kilogram per hour for at least 6 hours post-procedure. And initially, this became so popular that many institutes have started following this kind of soda bicarbonate infusions before and after the procedure. But current studies have showed there is not much benefit with this hypertonic solutions. But nevertheless, for exams, you need to know. So hydration is the key. But ultimately, in exam, if they ask you the first thing, it boils down to the isotonic solutions. Like simple normal saline is more than enough. Just adequately hydrate. That's all. That's the final take-home point. So there is very borderline role of N-acetylcysteine, Mucomyst. It's available as a common brand name called Mucomyst. N-acetylcysteine has some borderline benefit, but apart from that, you don't have much to do with N-acetylcysteine as well. So doubtful only. But because it's low cost and it's not toxic also, we use in and out N-acetylcysteine. But in reality, in trials, it's of doubtful benefit only. But the only thing that ultimately you should know for exams is the hydration. How many ever times I tell, this should be the one. Now, apart from that, you have other vascular causes. Number one vascular cause we discussed is atherioembolic disease. And we have many other vascular causes as well. Like for example, you're going to have this TMS typically, which we not discussed till now. That's thrombotic microangiopathies. As far as TMS is concerned, we have many different types of thrombotic microangiopathies. But there is a characteristic TMA triad, thrombotic microangiopathy, where you're going to have a microangiopathic hemolytic anemia. So what do you mean by a MAHA? In microangiopathic hemolytic anemia, there will be sharing of the RBCs, which means it's a typically an intravascular hemolysis. And that is due to tearing and sharing of the RBCs. So they'll be having cystocytes in the peripheral smear, which is very classic. And along with it, they'll be having extremely high LDH, low haptoglobulin. And they might be having hemoglobinuria also. These are additional stuff. But the most important point is MAHA, seeing cystocytes. This is the most important point. Apart from that, they will be having low platelet due to a variety of reasons. That is thrombocytopenia. And they'll be having some end organ failure. This end organ failure can be kidney or central nervous system, or probably even a GIT, gastrointestinal tract, or could be anything else. Typically affected is the kidney and the CNS. These are two things that are very commonly affected. But nevertheless, there will be some element of end organ failure in thrombotic microangiopathies. There are many different types of thrombotic microangiopathies. And there are many different conditions which produce TMA like picture probably. Like what are the conditions that produce? Typically what you need to know for exam is HUS and TTP complex, which produces thrombotic microangiopathy. Second thing that produces is your DIC, which is extremely common. Third thing that produces is accelerated hypertension or malignant hypertension, which can produce TMA like picture. That is thrombotic microangiopathy. Next we have something called a scleroderma renal crisis, which can produce a TMA like picture. That is because the sclerosis of the vessels that happen in the kidney in scleroderma. Especially it happens in diffuse scleroderma. I told you 2 antibodies that are having a high risk of SRC, that is anti-RNA polymerase 3 and anti-topoisomerase 1 antibody, that is anti-SCL70 antibody. Both these antibodies have high risk of producing SRC. In that, anti-RNA polymerase 3 antibodies have the highest risk of producing SRC. Or it can happen in patients with eclampsia or severe preeclampsia. Severe preeclampsia. Whenever I tell eclampsia or severe preeclampsia, I can also think about HELLP syndrome also, which can also produce this kind of picture. And next thing which can produce TMA-like picture is the APLA syndrome, antiphospholipid antibody syndrome. So these are the conditions that typically produces TMA-like picture, thrombotic microangiopathy. They can get this characteristic triad: MAHA, low platelets, and end organ failure. In that APLA syndrome we have discussed already, so I'm not going to discuss about that. Eclampsia and preeclampsia, you know what I'm going to do. In all these three situations, the best treatment is always delivery. That's the best treatment, but you can treat supportively. But the, like, if at all you get eclampsia, the only treatment available is delivery, nothing else. Even though you give magnesium sulfate to control the seizures, but once a pre-eclamptic patient gets a fits, becomes eclampsia, the only treatment here is delivery. Magnesium sulfate only to control the seizures. Severe preeclampsia can be observed, but nevertheless the best treatment is again delivery only. HELLP syndrome, and again the best treatment is delivery. Sometimes in postpartum period also you can get all these problems, even though it's rare. It's not like only in antepartum period you will get this preeclampsia, severe preeclampsia, and HELLP. Even in postpartum period you can get this eclampsia, severe preeclampsia, and HELLP syndrome. But postpartum problems can be managed more supportively and conservatively, because nevertheless the placenta is the problem in all these conditions. So once you remove that out by delivering the fetus, so this problem should automatically resolve. But there is a small risk of getting this problem in the postpartum period also. So typically in exam you will have a pregnancy history. Whenever you have pregnancy history, along with it, if you see a TMA picture, go for eclampsia, severe preeclampsia, or probably HELLP. HELLP easily you can diagnose by elevated liver enzymes. Elevated liver enzymes, that's a characteristic clue as far as HELLP syndrome is concerned. And as far as eclampsia is concerned, you will have fits. In severe preeclampsia, there will be no fits, but there will be heavy proteinuria, increased proteins in the urine, heavy proteinuria, edema, blurring of vision. So all these things will happen in a severe preeclampsia. It's easy to differentiate in exam. So background pregnancy or a history of recent delivery, getting all these problems, whatever I've told you, along with the TMA-like picture, you're going to go for preeclampsia, eclampsia, or HELLP syndrome. And remember, in HELLP syndrome, one important differential diagnosis, something called AFLP, is there. It's called acute fatty liver of pregnancy. So in exam, it's very easy to differentiate. In real time, whenever you get an acute fatty liver of pregnancy, which can also mimic something like an HELLP syndrome, because here also you'll have increased liver enzymes. So how to differentiate is, these patients will have signs of liver failure, like coagulopathy, encephalopathy. So liver failure signs will be there. Hyperammonemia will be there. All these things is not a feature of HELLP syndrome. And nevertheless, in AFLP, you won't have hemolysis. Low platelets and liver enzyme elevation may be there in AFLP also, but you won't get that hemolysis in AFLP. At the same time, you won't get liver failure signs in HELLP syndrome. So the presence or absence of liver failure is very important to differentiate AFLP versus HELLP in exam. And apart from that, malignant hypertension. Malignant hypertension, we know a patient is already having hypertension, coming with very severe hypertension. So you know how to treat a malignant hypertension. There is separate hypertension guidelines which I've told you that will help you. SRC, we know patient will be having a history of diffuse variety of scleroderma, getting a sudden renal failure and a TMA-like picture. It's a SRC-induced TMA. Treatment of choice here is, of course, ACE inhibitors, but definitely not ARBs. ACE inhibitors are the ones that are going to work very nicely here. As far as HUS, TTP and DAC is concerned, this is where the confusion usually is. That's what we're going to see. Two things. One is HUS TTP complex, and second is the DAC, that is disseminated intravascular coagulation. Most importantly, the first thing I need to see is the D dimer, PT, APDT, INR. I mean, that's coagulation process. This is what the first thing I'm going to see. As far as HUS TTP is concerned, it is normal, whereas DAC is concerned, it will be elevated. But among all this, the most important is the D dimer only. D dimer is the only thing that is always elevated, irrespective of the duration of DAC. It's acute DAC or a chronic DAC or a subacute DAC, no matter what, D-dimer will be elevated. PT-APT-INR is variable in DAC because in late DAC, for example, in a chronic DAC, in certain situations where you have a long-standing DAC, the liver might start synthesizing more coagulation factors, so they might normalize the PT-APT-INR. But D-dimer is something that will be always elevated because there is always some thrombosis and fibrinolysis that is going on in the body that will definitely elevate the D-dimer. So D-dimer is a consistently elevated finding in patients with DAC, but in patients with HUS TTP complex, it will be definitely normal. That's very important. DAC, we know what are the things that are going to happen. So typically the causes of DAC is what something we need to know. We know that the most common cause of DAC is typically again due to severe endothelial injury. Severe endothelial injury is the one that causes disseminated intravascular coagulation. And the most common cause for that, we know it's gram-negative sepsis. Sepsis is the most common cause of developing a DAC. Apart from that, there are many other causes like septic abortions, obstetric causes are there. Then we can get with certain cancers, especially as far as exams are concerned, they will be talking about that AML M3, that's called acute promyelocytic leukemia. Usually APML presents with DAC only. Most of the time it presents with DAC. And you can get with the gastrointestinal adenocarcinomas or any other adenocarcinoma because they produce mucin. You can get DAC. And trauma, especially if it's severe trauma or after surgery, major surgery. So usually many conditions can cause DAC, but usually in exams, the first three are very, very important. Cancers, septic abortions, and gram-negative sepsis. Of course, sepsis is the commonest cause of developing a disseminated intravascular coagulation. As far as DAC is concerned, diagnose very simple. Treatment, you can use anything. Treatment is fully supportive. You can use platelet transfusions if there is severe bleeding and thrombocytopenia. You can use fluids if it's a septic shock. You can use cryoprecipitate if the fibrinogen levels are very low. So depending on what is the underlying problem, just you can start treating accordingly. So all these things can be used in a patient, or you can use antibiotics also if the patient is having sepsis as the cause. So everything can be used. There's nothing that is contraindicated as such in DAC. The most important thing is the treatment of underlying cause. That's going to be the most important. Because DAC is always something that is secondary to some underlying problem. So treatment of underlying cause is very important. As far as HUS TTP is concerned, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura is concerned, you can divide into predominant entities. So one is HUS and second is TTP, even though majority of the times it is inseparable. You cannot really separate these two, but you try to separate. So one is HUS, hemolytic uremic syndrome, where the primary problem is endothelial injury. So whereas TTP is concerned, the primary problem is platelet trapping. That's what happens in TTP. So endothelial injury can be due to two reasons. One can be due to either the toxin-mediated HUS, usually virotoxins. Second is non-toxin mediated, which means it's not due to toxin. But best example for this is complement-mediated HUS. Complement-mediated HUS. That's the example. There are many different types of HUS are there, but one example is a complement-mediated HUS that happens, which is not actually toxin-mediated, but still cause endothelial injury. As far as this TTP is concerned, platelet trapping is typically due to reduced ADAMTS13 activity. Reduced ADAMTS13 activity. ADAMTS13, we know it is the one that disintegrates the multimers of 1 Lebrun factor into small fragments, monomers of 1 Lebrun factor. But if there is low ADAMTS13 activity, there will be persistence of this multimeric 1 Lebrun factors, which is the reason. So maybe you know the virotoxins, we call them as Shigella-like toxins. It can come from many different organisms, but the most important organism that you will be asking in exam is that enterohemorrhagic E. coli. So since you are talking about toxin, it's very common mistake to be done in exam. We talk about enterotoxigenic E. coli. Remember, ETEC produces an exotoxin that typically causes traveler's diarrhea, not HUS. So this enterohemorrhagic E. coli, especially strains O157H7 and O104H4, and there are many other strains are there. These are the things that typically causes this hemolytic uremic syndrome. Usually, children will be affected more. They'll be having history of bloody diarrhea, Most of the times that is due to the enterohemorrhagic E. coli. History of bloody diarrhea will be there, and that is why this type of HUS is also called as HUS-D plus or called as a typical HUS. Other names for this toxin-mediated HUS is HUS-D plus and typical HUS. But even though there are a lot of other names, it's better to always call it as a toxin-mediated HUS rather than HUS-D plus or typical HUS. These are very unreliable names. Go for toxin-mediated HUS. That's the right name. And at the same time, how they're going to present is again like a typical triad, TMA triad. They're going to have microangiopathic hemolytic anemia. They will be having low platelets, thrombocytopenia, and they'll be having end organ injury, which is AK, is the prominent finding. AK is actually quite severe, which means usually serum creatinine will be more than 1.5 to 2. And at the same time, thrombocytopenia will be less severe. Even though there is thrombocytopenia, platelet count will be usually more than 30,000. And there will be a microangiopathic hemolytic anemia, so that cystocytes will be there in the peripheral smear. As far as typical HUS in children is concerned, it's only supportive treatment. There is no other treatment that is needed. If they go for severe AK, go for dialysis. Otherwise, there is no treatment. It's better to avoid antibiotics. Antibiotics flare up the HUS because by releasing more toxins, by killing the organism. So don't use antibiotics. The organism will go on its own. And no platelets, no platelet transfusions. Very, very important. No platelets, no antibiotics. This is the regimen that we actually give. But platelets can be given, suppose if you're having a severe bleeding because of thrombocytopenia, but nevertheless, that doesn't really happen in HUS. So you don't use platelets. Don't use platelets, no antibiotics, no platelets. So perhaps when very few conditions where platelets cannot be given. So for example, they ask for platelet contraindications. Typically HUS, and I'll go for TTP where platelets need not be given. And next thing is HITS. These are three conditions where I don't really use platelets. Perhaps if they ask you for contraindication of platelets, these are three things I will tell: HUS, TTP, and HITS. Heparin-induced thrombocytopenia type 2. That's called HITS. So in these three conditions, I don't really use platelets. I don't want to use platelets. Whereas this complement HUS is concerned, I told you, majority of the patients will be adults, and they may or may not have history of bloody diarrhea. That's not an important thing, but usually it will be due to either, like that factor H and I loss of function mutation, or factor B and propertin gain of function mutation. So most of the time there will be some congenital source will be there, some genetic background will be there. So majority of these patients with complement HUS will have overactivation of alternate complement pathway. I think we have discussed about that overactivation of alternate complement pathway yesterday. And because of that, they'll be having low C3. They might have a completely normal C3, C1 and all, but I mean C4, C1 and all, but they'll be having low C3. And this is a complement-mediated damage. And typical triad, once again, you'll have the same triad. You'll have MAHA, you will have low platelets, which will be less severe. And again, you will have a AK, which is going to be very severe. And very characteristic feature of HUS is this acute kidney injury only. That is the striking feature as far as HUS is concerned. And here the treatment, you have to use supportive treatment. Of course, you might be needing hemodialysis. Plus, you need to use one important treatment called eculizumab. Eculizumab is an anti-C5 monoclonal antibody that prevents the complement-mediated damage. Eculizumab is extremely helpful in 100% response. 100% response. So this kind of complement-mediated HUS and other forms of HUS that is not toxin-mediated are also called as atypical HUS or HUS-D minus and all. But these terms should be strictly avoided. So why? Because there might be some CNS involvement in approximately 30% of individuals. You might have CNS involvement, and there are some cases where you can have GIT involvement also, like bloody diarrhea in 30%. That is because of the damage caused by this disease itself, not because of the bacteria. So that's why this diarrhea minus terms and all is very unreliable, where patients might have some CNS involvement in complement-mediated HUS. So that's very important. Suppose if the patient is having CNS involvement, you can add plasma exchange. Plasma exchange is added if the patient is having CNS involvement. So whenever there is CNS involvement, plasma exchange is extremely helpful. As far as TTP is concerned, I told you ADAMTS13 deficiency is the most important thing. This ADAMTS13 deficiency may be either a congenital deficiency, which is referred to as Upshaw-Shulman syndrome, Upshaw-Shulman disease, or it could be an acquired deficiency, which is very commonly due to antibodies like SLE. Example, SLE can produce antibodies against this ADAMTS13, can produce a reduced ADAMTS13 activity and thrombotic thrombogenic purpura. But most common is acquired only. 2/3 of the case will be acquired only. Only 1/3 will be congenital. But whatever may be the fact, majority of the patients will be adults. And the characteristic pentad that is a certain pathology itself, I'm not going to talk about that. But the main problem in TTP is you have a vessel, and let us assume if there is ADAMTS13 activity, what will happen? If there is no ADAMTS13 activity, what will happen? Suppose if you have ADAMTS13, so let us assume you have a normal ADAMTS13. ADAMTS13 is normal. What's going to happen is these multimers of von Willebrand factor will be cleaved by this ADAMTS13, and they'll become small monomers of von Willebrand factor, which is going to easily move into these vessels. But if you do not have this ADAMTS13, then you cannot cleave this bigger fragments, which means you are going to have this multimers circulating just like that. And this multimers of von Willebrand factor will actually start getting deposited in the smaller vessels. And von Willebrand factor is something, these are the multimers of von Willebrand factor. Remember, multimers are more active than monomers. Monomers are actually less active. More the size of von Willebrand factor, more the activities. So one end they are going to bind to collagen, another end they're going to bind to the platelets. So this is how von Willebrand factor is. So which means one end they can bind to the endothelium, and the other end they will start trapping the platelets that are moving on the way. So platelets, whatever they are moving on the way, they'll be trapped within this place, and they'll form a meshwork, and as a result you are going to have a reduced perfusion to a particular organ. End organ damage. So that's what is going to happen. So that's why I clearly told you this ADAMTS13 activity, when it is reduced to TTP, which is basically due to platelet trapping rather than endothelial injury, you're actually having a platelet trapping here. That's what is seen. So because of that, you will be getting a characteristic triad once again, the same microangiopathic hemolytic anemia that you're going to get. Apart from that, you will be having a low platelet, that is thrombocytopenia. And along with that, you will be having end organ failure. But as far as TTP is concerned, end organ failure that is classical is CNS involvement. Encephalopathy, seizures, stroke-like picture. So they might getting CNS, central nervous system involvement, which is very classical of a TTP. They might have an AKI, plus or minus, but it will be less severe. They might have a GAT involvement also in 30% of individuals, which can produce bloody diarrhea. So bloody diarrhea is not a differential diagnosis in reality, but in your exams, bloody diarrhea means it goes towards a D plus HUS. But in reality, blood diarrhea does not really tell you this is a HUS or a TTP or atypical HUS, doesn't matter. So, but here the low platelets will be very severe. Because of severe trapping, the platelet count will be less than 30,000. But AK will be less severe, it will be usually less than 1.5 to 2. Serum creatinine will not be elevated that much, even if there is an AK. Usually, I'm not telling always, usually this will be the case. But nevertheless, it's very difficult to differentiate between these causes. In order to clearly differentiate HUS and TTP, we need to know the ADAMTS13 activity. There are some tests that do ADAMTS13 activity. In TTP, ADAMTS13 activity will be less than 5% by definition, whereas in HUS patients, ADAMTS13 activity will be more than 30% by definition. So 5 to 30% is a gray area. So again, that is not very helpful. It's always a clinical judgment that's going to be very important. As far as TTP is concerned, the treatment is also quite simple. We are going to use only plasma exchange. But the final take-home point is very simple. In reality, in clinical practice, whenever there is CNS involvement, I'll go for plasma exchange. If there is no CNS involvement, I try to treat supportively. And once again, no platelets, no platelet transfusion, no platelets, no platelet transfusion unless you have significant bleeding. Otherwise, you are not going to give platelets. So these are differences between HUS, TTP versus atypical HUS, or what we call it as a complement HUS. So I think complement HUS we have discussed in detail in the previous session itself. So don't want to tell much about it. As far as the vascular cause is concerned, we have discussed on the vascular causes also. And we have some special causes are there. For example, we have maybe tumor lysis syndrome and rhabdomyolysis. These are the only two special causes that you need to discuss because they're routinely asked in exams. So let us discuss on these two, and I'll give a small break after that. Don't worry about that. So let us first finish off the pigment-induced nephropathy. Pigment-induced nephropathy. So typically we are talking about a rhabdomyolysis here, RBM. So here the pigment is myoglobin that is causing the problem. So usually rhabdomyolysis will have some underlying cause will be there. Like for example, in exam, if you have history of crush injury, or if you are having a prolonged immobilization. Like for example, patient with benzodiazepine toxicity, patient who is taking acute severe ingestion of alcohol, knocked out, staying completely immobilized for a long period of time, and severe obesity. Those patients can go for spontaneous rhabdomyolysis also because of severe immobilization in a morbid obese patient. Or if the patient is having some orthopedic surgeries, especially arthroscopic surgeries. This is something important to know because sometimes I can see with this arthroscopic surgeries. So why with arthroscopic surgeries? Because whenever they do a knee arthroscopy or any other arthroscopic surgery, they put a tight tourniquet. Whenever they put a tight tourniquet, there will be severe muscle ischemia in these guys, and because of that, they can go for rhabdomyolysis. So, I mean, arthroscopy, they put a tight tourniquet because to create a bloodless field. If there is a prolonged arthroscopic surgery or the surgery exceeds the cutoff time, beyond that, you're applying the tight tourniquet, there's always a risk of developing rhabdomyolysis. And it can happen in a patient who's having a neuroleptic malignant syndrome because of severe muscle rigidity and contraction. And similar condition is status epilepticus because of severe muscle contraction. They go for rhabdomyolysis. And the electrolyte disturbances itself can cause rhabdomyolysis, like if you have a hypokalemia. Hypokalemia is a very important cause because hypokalemia produces vasoconstriction because more potassium means you get a good vasodilation, and less potassium, you will go for a vasoconstriction, ischemia to the muscles, and of course, you will get rhabdomyolysis. And remember, that is also the reason why during exercise, the muscles release potassium because during exercise, they need more blood. So they release potassium that causes vasodilation, so they produce more blood flow to the muscle. So whenever there is hypokalemia, that is reversed and they can go for rhabdomyolysis during exercise. Hypophosphatemia, similar effect, and you can get with hypomagnesemia also. But the most important thing is hypokalemia only, which is extremely important. And it can happen with certain drugs. Many drugs can cause, but the most important drug, as far as I know for exams, is maybe succinylcholine, very commonly asked in exam. It's a deep potassium neuromuscular blocker and can happen with statins. But remember, unless and until you give statin with another enzyme inhibitor, because statins are metabolized through CYP3A4. And if you give another powerful 3A4 inhibitor like azole antifungal drugs or HIV protease inhibitors like ritonavir, you don't really result in a rhabdomyolysis. So even with the extreme doses. So statins induced rhabdomyolysis as such is very rare, but if you're giving a powerful enzyme inhibitor, along with it, you might result in development of rhabdomyolysis. And apart from that, if you have a compartmental syndrome, which again happens in a crush injury, so it can cause rhabdomyolysis. There are many different causes, but in exam, usually they will consider arthroscopic surgery, post-arthroscopic surgery, rhabdomyolysis because of tight tourniquet. And there are other areas where you can have a tight tourniquet, like snake bite. Even though snake bite is not directly myotoxic, except for the sea snakes which are myotoxic, your viper or crate or cobra is directly not myotoxic. So usually this should not cause rhabdomyolysis, but usually it is the error that is caused by the public by putting a tight tourniquet for a long time. Snake bite patients may have associated rhabdomyolysis. So these are some of the areas where you can get rhabdomyolysis. So in India, usually, like Indian exam, they might ask about the snake bite, arthroscopic surgeries, prolonged immobilization, status epilepticus, hypokalemia, succinylcholine. Succinylcholine is very commonly asked in old exams. Right now, they don't ask. I don't know why in the last 4 years I didn't get any question on this choline-induced rhabdomyolysis. Okay. So as far as this rhabdomyolysis is concerned, here the muscle is lysed. So you know what are the problems you're going to face when the muscle is lysed. Suppose if the muscle is lysed, you're going to result in myoglobin. leakage. So the free myoglobin levels will be really elevated in the blood. This free myoglobin will actually cause multiple effects, but in the kidney, they are going to induce severe vasoconstriction. At the same time, they are directly toxic, deposition in the tubules. And they are directly toxic as well, deposition in the tubules. So because of that, they can go for acute kidney injury. Acute kidney injury. So typically, this acute kidney injury will have increased urinary myoglobin. If you have any testing for myoglobin, you can do directly increased urinary myoglobin will be there. Apart from that, there will be some characteristic presentation which I would have discussed multiple times in the past, like your dipstick will show positive for blood. Dipstick will be positive for blood, and it will be strongly positive for blood because dipstick detects heme. Dipstick detects heme, and it cannot differentiate between hemoglobin versus myoglobin. Both have heme groups, so you cannot differentiate between hemoglobin versus the myoglobin. So the dipstick will tell there is a strong positivity for blood. But if you take the sediments will not be there, no RBCs and no RBC cause. If you take the sediments, they will show typically there will be no RBCs. If it's no RBCs and dipstick is showing serious amount of positivity in blood. So only two conditions, either it could be a free hemoglobin or a free myoglobin. So there's a differential diagnosis exam. Dipstick positive heme with no RBCs, but no RBCs in the urine. So this only two differential diagnoses. It could be a free hemoglobin or a free myoglobin. In this setting, I can diagnose this. Either it's a hemolysis or either it's a rhabdomyolysis. So in both these conditions, elevation of LDH may be seen and elevation of CPK may be seen. But remember, LDH elevation more than CPK, think about hemolysis. CPK elevation more than LDH elevation, think about rhabdomyolysis. If your primary problem is CPK elevation, think about rhabdomyolysis. If your primary problem is LDH elevation, think about hemolysis. Very important. So that's how you differentiate based on parameters, but there will be a clear-cut history will be there, whether it's a free hemoglobin or free myoglobin. But nevertheless, this is a very, very important concept in exam. Apart from that, your enzymes will be released. That is the reason why I'm telling CPK, LDH, aldolase enzymes will be elevated. Aldolase B will be elevated, but very importantly, my CPK elevation is very important, and it's actually correlating with the extent of AK also. Suppose usually AK is common if CPK levels are more than 10,000. Usually if CPK levels in the 10,000s, AK is extremely common. If CPK levels are less than 10,000, AK is very, very less common. It won't happen. And number 3, electrolytes. Electrolyte problem that they're going to face. The most important electrolyte that the muscle is going to release is hyperkalemia. Another important electrolyte that the muscle is going to release is phosphate. So there will be hyperphosphatemia. And this phosphate will definitely combine with calcium, producing a calcium phosphate compound. So thereby resulting reduced free calcium, causing hypocalcemia. Whenever you see hyperkalemia, hyperphosphatemia, hypocalcemia, please don't think straight away rhabdomyolysis in exam. There are multiple differential diagnoses. In reality, the first thing I will think is a CKD patient, because CKD patients also have hyperkalemia, hyperphosphatemia, and hypocalcemia. So don't jump into conclusion that is rhabdomyolysis. This is one finding that can be seen in many other conditions. So this is what you're going to see typically in a patient with rhabdomyolysis also. And in this, the most important I feel is the hyperkalemia only. That is why any rhabdomyolysis patient, you have to take an ECG always, because hyperkalemia is so common in rhabdomyolysis, because muscle is actually a storehouse of potassium. When muscle is lysed, of course, you will result in hyperkalemia. And that's why, I mean, if they ask you in exam, if the patient is having rhabdomyolysis and hyperkalemia, the next step what you do is always ECG, because I need to rule out hyperkalemia related cardiac problems, which can even result in death of the patient. Even before the AK causes death, the hyperkalemia can cause death. So that is why I need to rule out that first. So I do always ECG as the next investigation. And apart from that, investigation wise, I told you how to detect a rhabdomyolysis. You can do a biopsy if you want, but actually classically not needed. CPK, this AKI and electrolytes itself will be history or itself will be suggestive of rhabdomyolysis. As far as treatment is concerned, the most important treatment is hydration. Hydration, 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 hydration. That's the most important. Again, IV fluids typically I use isotonic saline. That's more important. And I need to maintain urine output if it's possible at rate of 250 to 500 ml per hour. Most of these patients will be non-oliguric only. So if at all possible, maintain urine output at 250 to 500 ml per hour. If you can maintain, suppose the patient becomes oliguric, not producing urine, going for volume overload state, don't give fluids. So then you have to go for standard severe AKI management like hemodialysis and all. But if the patient is having good urine output, try to achieve so much of urine output by giving too much of hydration. Typically maintain urine output in the range of 250 to 500 ml per hour. So that is due to prevent that deposition of myoglobin in the tubules. So flush everything out as much as possible. And second is urinary alkalinization. Second is urinary alkalinization. So in this, typically you maintain a urine pH of more than 6.5. Urine pH of more than 6.5 or maybe even 7. So normal urinary pH is 4.5 to 6.5. That's what you need to know. We have discussed multiple times in the past. You have to maintain the urine in the alkaline pH because urinary alkalinization may increase the excretion of myoglobin to a large extent. So we know that. So typically we give soda bicarbonate infusions for that. It's an alkaline diuresis, not a forced alkaline diuresis. I just need to maintain urinary pH at more than 6.5. If nothing works, you might be needing a hemodialysis. If the patient goes for severe AKI and the patient has to go for so many problems, you might need a hemodialysis, but most of the times hemodialysis will not be needed. You can manage more conservatively itself. Is there any role for diuretics? Diuretics typically, as far as diuretics is concerned, loop diuretics have no role, but they have given some experience with another diuretic called mannitol. But currently, again, it's a big no. Currently, again, many trials tell no, you don't use mannitol. But previously, in the beginning, they have been using mannitol because mannitol being an osmotic diuretic, it takes a lot of fluid from the interstitium and the tubules, from the interstitium and the tubular cells into the lumen. So what they believed is, if you give a osmotic diuretic by taking off more water, it will dilute the myoglobin so that you can prevent the deposition of the myoglobin by absorbing more water from the surroundings. But later on, we know that mannitol is not that effective, and sometimes it can even worsen the AKI caused by rhabdomyolysis because there is another component that is involved in rhabdomyolysis, that is your vasoconstriction. I told you already. Rhabdomyolysis is something, this free myoglobin is something that's going to cause severe vasoconstriction also. So by excreting more volume, they might produce a sort of imbalance in the volume status in the body, producing more hypovolemic state. And this vasoconstriction may cause more and more hypovolemia and more reduced perfusion to the kidneys, resulting in worsening of AKI. So the trials are controversial. Diuretics, loop, definitely no role. Mannitol, you can use. Suppose if there is a very primitive question like, which of the following is a diuretic of choice in rhabdomyolysis? If they ask you questions like that, then you can go for mannitol. But as such, diuretics have no role, and mannitol is very controversial. But currently, we don't use it. Most of the nephrologists avoid mannitol in rhabdomyolysis. In fact, mannitol itself can cause that osmotic AKI. So you should not do that. So hydration, urine alkalization are the mainstay. So hydration is the most important. One thing that is important in rhabdomyolysis, that is hydration, which is extremely important. And next, a special cause of AKI is tumor lysis syndrome. It's an oncologic emergency. Tumor lysis syndrome is basically an oncological emergency. As far as tumor lysis is concerned, the tumor is going to produce certain things that you need to know. First of all, tumor produces high cell turnover. So let us take a tumor cell. So number one, due to the increased turnover, high cell turnover of the tumor cell itself, there are some risk factors like producing more uric acid, hyperuricemia. Because of hyperuricemia itself, they can produce monosodium urate crystals in the kidney and the urine, which can get precipitated and they can itself result in acute kidney injury. Point number one. So second thing, if this tumor cell lysis, if they go for lysis, especially this happens after chemotherapy, post-chemotherapy. Usually it happens, or it can happen spontaneously. Rarely it can be spontaneous. Lysis can happen, but usually it will be after chemotherapy. After chemotherapy, if you get a lysis, they can release a lot of substances. Like for example, they can produce hyperkalemia. Typically, as per the definition, it should be more than 6 milliequivalents per liter. Or they can produce hyperphosphatemia. That is because the tumor cells have a high phosphate turnover. Because of that, they can release more phosphate. They can produce hyperphosphatemia. And typically, as per the definition, if the phosphate levels are more than 6.5 milligrams per deciliter, or if it is increasing by more than 25% from the baseline. 20% from the baseline. Because there are some conditions like multiple myeloma where the patients will have high phosphate already. So in those conditions, very difficult to determine. So that's why 25% from the baseline is given. And next thing is hypocalcemia, because this high phosphate will actually bind with calcium and they'll produce calcium phosphate. And there are many studies that are telling something called a calcium phosphate product ratio is there. So where they multiply the calcium and the phosphate and find out a product, because this calcium phosphate product is actually very important, because more the calcium phosphate product, more is the risk of AKA, because they can also crystallize. That's the problem. So AKA. But one important point to note that is this uric acid crystals can be eliminated by urinary alkalization. Urinary alkalization basically increases the elimination of uric acid crystals, but there are only two crystals that actually get deposited, actually gets precipitated with urinary alkalization. One is calcium phosphate crystals. They actually precipitate. They don't get eliminated. They get more precipitated with urinary alkalization. That is why it's very important to know when to alkalize urine and when not alkalize urine. If it's a uric acid problem, then you can alkalize the urine. But if it's not a uric acid problem, if it's a calcium phosphate related problem, then you should not alkalize the urine. In fact, alkalization will have worst outcomes. It will worsen the AKA because calcium phosphate will get precipitated. There are two crystals which precipitates with alkalization. One is calcium phosphate and second is your struvite crystals, which are discussed already, the triple ammonium phosphate crystals. This and calcium phosphate crystal will basically precipitate the alkalization. You should not do that. So this is the reason for development of AKA. That's very important, because if they give a patient with a tumor coming with an AKA, so it could be a tumor lysis. It cannot called as a tumor lysis syndrome, but it's actually due to high cell turnover, and usually it will be due to monosodium urate crystals. Suppose if a patient comes with AK after a chemotherapy, it's equal to established tumor lysis syndrome. That's called an established TLS. After chemotherapy, if the patient comes with an established tumor lysis syndrome, it will usually be due to calcium phosphate. Pre-chemotherapy, it will be usually due to high cell turnover. It's not an established tumor lysis, but after chemotherapy, it will be usually due to an established tumor lysis. So low calcium in the sense how much there should be hypocalcemia. So in the sense, hypocalcemia means it should be either less than 7 milligrams per deciliter, or it could be more than 20% decline. Okay, right? Less than 7 milligrams per deciliter, or more than 20% decline from the baseline calcium. So number one. So this 7 cannot be kept as a cutoff, because there are some tumors which will have high calcium already, like 12, 13 and all will be there, like multiple myeloma and many other osteoclastic metastasis, lytic metastasis, you might have a high calcium level. So in that setting, you cannot keep a cutoff of 7. So more than 20% decline in that situations may be very significant. Uric acid also has a cutoff. Suppose if the uric acid levels are more than 8 milligrams per deciliter, normal uric acid is up to 6.5, 6.7, you can keep it as normal uric acid. But if it's more than 8 milligrams per deciliter, then once again, there is a possibility of tumor lysis. These 4 cutoffs is very important. There are 4 things that happen in tumor lysis: hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia. Together with this cutoff is together the cutoffs, this classification is what we refer to as a Cairo-Bishop criteria for diagnosing tumor lysis syndrome. So hyperuricemia more than 8, hyperkalemia more than 6, then hypocalcemia less than 7, and hyperphosphatemia more than 6.5. So why hypocalcemia? That is because of the phosphate and calcium combination. Hyperphosphatemia produces calcium phosphate automatically, and that is the reason why you deplete the free calcium, producing a calcium phosphate. That's the reason. Okay, fine. So this is Cairo-Bishop criteria, and this is how you get a tumor lysis syndrome. It's an oncological emergency. So treatment is dependent on what is the problem. Suppose if you get a AK in a patient who's having a tumor, so you need to see whether it's pre-chemotherapy or a post-chemotherapy. Usually in exam, this tumor will be a hematological cancer only. Usually it will be a hematological cancer. Getting a solid organ cancer is very rare. Usually it will be a hematological cancer. Usually getting a tumor lysis in a solid organ tumor like breast cancer or lung cancer or renal cancer is extremely rare. There are reported cases sporadically, but usually it is rare. It's not going to happen in exam. And Hodgkin lymphoma, please rule out. It's not possible in Hodgkin lymphoma. Solid organ tumors and Hodgkin lymphoma typically does not cause tumor lysis, but it can happen in the setting of hematological cancers like leukemias and non-Hodgkin lymphomas. There are certain factors that are considered as high risk. High risk tumors are those which have very high counts, like AML more than 50,000 or ALL more than 1 lakh cell count, WBC count. So very high risk. And high grade non-Hodgkin lymphoma. High grade non-Hodgkin lymphoma, usually the first thing that should come into your mind whenever I tell a high grade lymphoma is Burkitt's lymphoma or a Burkitt's leukemia. That's the first thing, extremely high grade. High risk of tumor lysis. Among all the NHLs, if you ask highest risk of tumor lysis, Burkitt's only. Then followed by maybe DLBCL. So, but Burkitt should be the first. And low risk, typically, if AML is less than 50,000 or ALL with less than 50,000 count, 100,000 count, low risk, and low grade lymphomas, including multiple myeloma. Low grade including multiple myeloma. Clear? Low grade including multiple myeloma. So these patients automatically you need to give a prophylaxis, even whether their tumor lysis is there or not, whether hyperuricemia is there or not, automatically this patient should be given prophylaxis. Suppose if it's a high grade tumor, high risk case, then typically we'll give rasburicase to bring down the uric acid levels. How long you'll give rasburicase? Till the tumor is controlled. For example, if the counts, of course, you're not going to only give rasburicase with this count and with this high grade lymphoma. Once you have diagnosed, you're going to start with chemotherapy. So before starting chemotherapy, of course, I need this rasburicase for sure because it's a high risk tumor. Once you start chemotherapy, even there is a substantially higher risk of developing tumor lysis. And if it's going to be a low risk tumor, then in this condition, allopurinol alone is enough. Allopurinol alone is enough in this particular situation. I don't really need any other thing. Remember, typically speaking, febuxostat is not approved for prophylaxis in tumor lysis, and pegloticase that you use for gout is not approved for use in tumor lysis. These are two small points that you need to know. Apart from that, we either use allopurinol or either use rasburicase. Anyone you can use, but combination is again not very useful. But this is a prophylaxis that we are going to give before starting chemotherapy. So which means pre-chemotherapy, if you see an AK, usually it will be due to high uric acid. So because it is due to high uric acid, you can initially start giving allopurinol. As the first step, you can start giving allopurinol. If the patient is not responding to allopurinol, then probably I can start with rasburicase. Still, if the patient is not responding, AKA persisting, then I need to think about other causes. Probably it could be a tumor-induced glomerulonephritis also. So glomerular disorders can be there. So I need to think about the urinary analysis again to look for sediments or maybe biopsy sometime. But usually we don't do because these patients will be highly having a bleeding tendency. So putting a needle into the kidney, nobody will do that in that setting. So if AK is persisting, straight away go for hemodialysis. That's all. Take the patient for dialysis. If it's a post-chemotherapy, there are two reasons. One, usually it will be due to calcium phosphate, or it will be due to uric acid also. But typically, like in post-chemotherapy, calcium phosphate is the reason. Uric acid might be the reason, but calcium phosphate is also the reason for developing post-chemotherapy. In this setting, usually I don't go for any of the things. Straight away go for hemodialysis. That's all. There's no need to really, worry about much things here. straight away go for hemodialysis. No need to give anything else because calcium phosphate does not respond to your allopurinol or raspberry acid. I mean, post chemotherapy in the sense already. Why another point? What you need to know is if you are giving a chemotherapy, no hematologist, practically speaking, is going to start with chemotherapy unless and until you have started already a hypouricemic agent. So already the patient will be on. Most of them will be already on some hypouricemic agent like allopurinol or raspberry acid. So if they are already on a hypouricemic agent, there's no point in giving a hypouricemic agent once again. So stop it. I mean, just dialysis. That's the most important thing. So post chemotherapy, dialysis is the main thing. Pre chemotherapy, you can try with uric acid lowering agents, then you can move on to dialysis. But one more important thing is that if this is due to increased uric acid, you can use additionally urinary alkalization, if possible, where urine pH more than 6.5. Target urine pH more than 6.5 to 7 is what I'm going to maintain. I can do an additional urinary alkalization, but here in post chemotherapy, urinary alkalization is actually contraindicated. You should not do that. Which means in an established tumor lysis syndrome, you cannot give urinary alkalization because calcium phosphate will get precipitated more in patients with who are going for alkaline urine. So don't do that. So, but in pre-chemotherapy, yes, you can. But in post-chemotherapy, no, I don't. So this is what I'm going to do. And we do have some other conditions, I think, where you need to discuss. Maybe we can discuss after the break because I wanted to talk few things on obstructive uropathy. At the same time, we need to discuss maybe on something else also. I mean, dialysis. That part is also there, which we'll be discussing after the break. We can go for a break and we'll start by 7 o'clock again. Bye-bye.